Well, good morning, everyone. Thank you to all who traveled in a bit of weather this morning to be with us. We appreciate you being here. I will officially call the meeting to order and also note that this meeting is being recorded. And I will turn it over to the team for roll call, please.
Good morning. Dr. David Carlisle.
Present.
Dr. Sandra Hernandez. Secretary Kim Johnson.
Present.
Richard Kronick.
Present.
Ian Lewis. Elizabeth Mitchell.
Present.
Dr. Richard Pan. Don Moles. 4 present. We have quorum.
Thank you very much. And Director Landsberg, I will turn it over to you to start us off.
Thanks very much, Madam Chair. Good morning, everyone. Also appreciate you being here today. I will note Sandra Hernandez isn't feeling well this morning, so she sends her regrets, and we anticipate Dr. Pan will be joining us. So in terms of our agenda today, our meeting is focused on 2 important topic areas: an introduction to the behavioral health definition and investment benchmark, and then a continued discussion of sector targets. So our staff has done a lot of detailed work looking at the data on hospital costs and options for sector targets, as the board has asked us to do, and we look forward to your input. I will take note that this is an informational item and we will not be taking action on sector targets today. And then I will move, if it's okay, onto the executive updates. So this being the last Affordability Board meeting of 2024, I did want to take a few moments to reflect on the accomplishments of both the office and the board this year, and to thank our staff, our wonderful staff behind me in the room, online, each of you as board members, our advisory committee members, our many work group members, and other stakeholders for your contributions to our important work to address the healthcare affordability crisis in California. So I am a believer in doing some reflection at the end of the year, both in terms of our accomplishments and also setting our goals for 2025. So our accomplishments together this year were many. You all did adopt the first statewide spending growth target in California, and that in itself represents a lot of work to get there. So we heard from other states, we heard from consultants, we looked at many economic indicators to get to the target that you adopted. The Office of Healthcare Affordability always recognized that market consolidation is a significant driver of healthcare costs, so we stood up our cost of market impact review program this year, adopted the regulations, and while there were a number of transactions that hurried to be done by March 31st, starting in April, we started to receive those material notices and have been timely reviewing and making our decisions about those material transaction notices. On our value side, we have adopted a framework for measuring APMs, and you voted a goal for their adoption. The office adopted a primary care definition, and you set a benchmark for those. And then the office adopted the initial workforce stability standards. So very significant accomplishments on the value performance side of our work. We, of course, have been for a year and a half hearing from consumers in Monterey who have such a huge impact about the high cost of hospital care in their region. And so hearing their call and invitation to us, we did have our Monterey meeting and really did a deep dive on that data. And of course, that work continues. This year, the California State Senate confirmed the participation on this board of members Carlisle, Mitchell, Kronick, and Hernandez, and we welcomed Secretary Johnson to this board. We had many presentations on cost-reducing strategies from a range of healthcare entities showing us their innovative approaches to achieving high-value care and bringing costs down. We did a lot of data analysis, a lot of stakeholder engagement. We published our first data submission guide, and we have collected 2 years of THCE data, total healthcare expenditure data, an acronym I did not know 2 years ago. So we have done a lot of work together. So addressing healthcare affordability is a significant undertaking, and we so appreciate the partnership with each of you in the room, each of you online, and each who have contributed to us. And then our teams across OCA's 3 branches are filling out nicely. And as of today, we have a staff of 47 staff members, talented, hardworking people who are committed to our mission. So congratulations to Vishal and the team for that. So wanted to start my updates with that. I also wanted to note a perhaps somewhat unusual cost reducing strategy. So I sat in this room last Thursday for the Hospital Building Safety Board, another part of our work here at what was OSHPD, now is HCI. And we had a presentation from UC Irvine about the first all-electric hospital building in the country, a huge accomplishment. So they talked about electrification and decarbonization, and there are some upfront costs to making that commitment. And of course, it's very much driven by concerns about climate change and green goals. And it will also, over time, produce some healthcare cost savings. So that was kind of fun to hear in a different part of HCI's work about cost reducing strategies. And then last but importantly, I wanted to circle back on the issue of using HPD data for OCA's hospital measurement approach. Hospital spending measurement approach. So in terms of developing a measurement approach for measuring hospital spending, our work group continues to work on this, and we will agendize this for a future meeting in the first quarter of 2025 likely. So hospital spending measurement won't be a major topic of discussion today, but I told you I would give you a more specific answer about the use of HPD data and wanted to do that this morning. So you know, as we've talked about, and I imagine you concur, HCI's hospital annual financial data is the best source for us to use. We've been getting it for 50 years. It's audited by us. It's attested to by the hospitals. We have a high confidence in its accuracy and completeness. And fortunately, hospital financial reports have what we need on the inpatient side of hospital spending, right? So we know that we have that net patient revenue, the NPR, the net patient revenue, which is an accepted, commonly understood and used measurement of overall spending. We can derive the portion of net patient revenue that's for inpatient spending and then calculate this on a per unit level of spending by dividing inpatient NPR by the number of discharges. And then in terms of case intensity, we adjust the discharges by applying a case mix index. And that lets us to report a measure that accounts for inpatient intensity. So that's the inpatient NPR per case mix adjusted discharge, CMAD. So really we have what we need on the inpatient side from that very reliable hospital annual reporting. And then it's a little more challenging on the outpatient side, right? So we've described our approach to measuring outpatient NPR as an initial approach that can be enhanced over time. But there are some challenges in measuring spending for outpatient services because the HCI annual financial data includes data for total outpatient NPR, but doesn't collect information related to patient, the intensity of those services. So that's why we came up with the approach of the ECMADs, the equivalent case mix adjusted discharges to measure the units of outpatient services. And we acknowledge that this approach would use inpatient intensity as an input in performing this calculation. So a few of you have asked us to reevaluate this use of ECMADs and assess whether there is a better data source. And so the two logical places to look are either to ask the hospitals for additional reporting, which we're hesitant to do just from an administrative burden side, or to look to our HPD data. So we're certainly considering this while acknowledging the limitations of the HPD data, and that's what I wanted to talk a little bit about. So we are I want to make very clear, we're very proud of the HPD, the progress we've made in standing up the HPD program and building California's all-payer claims database, and there are some limitations. So the HPD data doesn't include all consumers, most notably most self-insured lives are not included, some are. We don't audit the HPD data as we do the hospital financial data, and it's not it's not attested to by the hospitals themselves. We're in the process of evaluating the completeness of the hospital data in the HPD. So the best benchmark we have to compare it against is our HCI patient discharge database. And so we went through an exercise of taking that HCI patient discharge database and comparing it to the HPD data for the top 10 facilities with the largest numbers of discharges, just as a comparison point, and found that the HPD had 65% of what was found in the discharge database, and we did publish that in our March report to the legislature. And we may have similar missingness on the outpatient services. So in looking at why that might be the case, it's really a matter of we think probably the encounter data is incomplete, right? There's a incentive to have the claims data that's needed for payments to be complete, and then for capitated services covered under capitated payments, we have encounter data, and there is some missingness of that encounter data. So we're continuing to study these issues of data completeness, which vary across hospitals. Another challenge is attributing claims data to hospitals, right? So a single hospital may have several subparts for billing purposes. So the data that's reported from the health plans to the HPD may have different, hospital A subpart, hospital B subpart. And so we have to figure out how to map those and aggregate them for proper attribution and in analysis of the data. There are also known issues related to consistent use of billing and rendering provider identifiers in administrative data. So we're working diligently to address this. One exciting, daunting, important project is to build the authoritative provider organization index that we don't have in California. And that would be important to use to identify and deduplicate the facilities and physician groups and map the organizational hierarchies and organizations and affiliations. So that could help address the provider attribution, and it's going to take some time. We're currently trying to assess what the scope of that project will be. So we believe that the quality of the data will continue to improve. In addition to the provider organization index, we're meeting with health plans who contribute to the HPD data about how to improve the data. Our staff continue to pressure test the data, and very excited that next month we will be opening the data release program for the HPD, which will result in large-scale use of the HPD data and will help us learn more. And that will be helpful in helping us uncover issues and finding solutions. So all this is to say that we're continuing to evaluate our options, including use of the HPD data for measuring outpatient hospital spending, and we will report back in a few months. I think we'll have a larger presentation on HPD data, which has been requested by this board, and we will plan for that in the first quarter of 2025. So I know that was a lot of information, but wanted to be responsive and reporting back. And with that, I will turn it over to Deputy Director Pagani.
Thank you, Director. I'd like to inform both the board and the public that our next meeting on January 28th will be held at a different location. It'll be the new May Lee State Office Complex off of Richards Boulevard in Sacramento. This will be HCI's new headquarters beginning this summer, but we will be transitioning our public meetings there starting in March due to limited technology infrastructure at this building. The January meeting will be held at this new location to ensure that it meets our needs for future board meetings. The exact address is at the end of this slide presentation and on our meeting website. And now, as we do at every meeting, just a reminder about our slide formatting. So the yellow arrow denotes areas for which the office has decision-making authority. It's important for us to get stakeholder input on these areas, and these meetings are an important way to engage with both the board and members of the public. For areas where the board has ultimate decision-making authority, it's noted with a green arrow. And that concludes my updates, and I'll turn it back over to the chair.
Thank you both, and thank you, Director, for taking us through those reflections, as well as kind of what's more to come on the follow-up related to the data information. Appreciate both of those, and we will look forward to our new location coming in the new year. Any questions from the board on any of those executive updates?
One comment, Elizabeth, on your statement that the annual financial disclosure data have everything we need, everything that's needed on the inpatient side. I'm not sure that's quite right. I mean, the data, my understanding, and others can correct me if I'm wrong, is that they have net revenue, that is the amount that insurers have or other payers have paid to the hospital. But with the exception of Medicare and relatively small amounts of traditional commercial insurance, that is non-managed commercial insurance, of which there is hardly any because almost everything is managed, either HMO or PPO, doesn't separate inpatient and outpatient revenue. And you know, there's the ability to estimate inpatient revenue by assuming that inpatient revenue might be proportional to the proportion of total charges that are inpatient. And I and other researchers have done that in the past. But that I think it's important for the members of the board and the public to understand that the data don't currently allow a hospital reported figure on inpatient revenue. And so if we're going to be using an estimate of inpatient revenue per case mix adjusted discharge, we should understand that the numerator of that is an estimate, and you know, sort of more not a fully accurate estimate probably. I mean, any estimate has error, but this one has, you know, potentially kind of troubling sorts of errors, and troubling sorts of errors that hospitals can potentially change over time if we are going to use the fraction of charges that are inpatient as a way of estimating inpatient revenue. Well, hospitals can, by changing their charge master, change the fraction of charges that are inpatient.
Thank you, Rick. That did come up in our hospital spending measurement work group, and we did lay out some options on how to enhance the HCI financials. One of them could potentially be to actually have the hospitals give us the actual amounts. Not all I'm not going to speak for all the hospital members in the group, but a few did speak up and say that they could provide that.
Thank you. And I should have said this was a plea or a exhortation to enhance the data and to get those data in the future.
Please, Elizabeth.
Thank you. That prompted my own plea for enhanced data on some of the specialty groups that are sort of below the system level, and, you know, particularly the acquired practices, like Optum acquired practices or Sutter acquired practices. Like, how do we make sure we're seeing all the way through, not just at the hospital level? I think that's going to be an important data source.
Yeah, thank you both for those important points. And I do hope certainly the goal for the physician organization index would be to get at specialty groups as well as hospital groups and primary care.
Okay, thank you both. We're going to now turn to public comment. Any public comment related to the executive updates is welcome now.
We'll now recognize members of the public for comment. To ensure equitable access, we will alternate between those present in the room and those attending virtually. Those in the room may line up at the podium. Those attending virtually can raise your hand. Those dialing in can press *5. We also invite you to provide written comments at the email address posted with the agenda. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda, except to place the matter on a future meeting agenda. I'll start with the individual at the podium.
Beth Cabell for Health Access. We had not planned to comment on this item, but the lengthy executive director's report on the HPD and the discussion of the board, as always, informs our thinking. It is correct that the staff has looked at updating some of the HCI hospital reporting to better reflect the outpatient reporting. I think there are a lot of improvements that could be made in the hospital reporting that reflect the fact that it has not been used for this purpose before. And whether that's standardizing how the quality assurance fee is reported or other changes, I think as we do this work, we will have to systematically improve things over time. And we're going to as we do this work, we will identify other things that need improving and appreciate that we have both the director and the secretary here so that the other parts of HCI that need to update their work to support the work of OCA can be supported in that. With respect to what we've been calling a provider registration, what you're calling a provider organization index, that's very important and complicated work. Having sat through a delightful discussion of the differences between tax ID numbers and NPIs, I don't think we're gonna, it's not readily solved, but it was foundational to Massachusetts doing similar work. And so we will look forward to that discussion continuing here in California. Thank you.
Thank you. Looking virtually, Dr. Zandra, I can't see the full name. Thank you. Dr. Galvin, please go ahead.
Yes, thank you so much. Can you hear me?
We can.
Okay, excellent. Thank you so much. I am the proud superintendent of the Salinas Union High School District in Monterey County. My subject for this public comment is urging the imposition of a 0.1% sector target for the 3 most utilized hospitals here in Monterey County. So as the superintendent of the Salinas Union High School District, I am here to express my deep concern regarding the significant and ongoing increases in healthcare costs, particularly those associated with hospital services. The exorbitant prices and the pricing practices of these 3 most utilized hospitals in our county have placed a substantial burden on our employees and their families. Effective January 1st of 2025, our employees will be experiencing a 12.47% increase. I'll share that again, 12.47% increase in medical premiums and a reduction in benefits due to these changes. We urge the Office of Healthcare Affordability, the board, to please take immediate action by imposing a strict 0.1% sector target on the 3 following hospitals: Community Hospitals of the Monterey Peninsula, also known as CHOMP, Salinas Valley Health, and Natividad Medical Hospital. This measure is essential to curb excessive pricing and ensure that healthcare remains accessible and affordable for all within our county, but most importantly, the employees that I serve on the Salinas Union High School District. The excessive cost of hospital prices and services has a direct and negative impact on, first, our employees and their families. The rising healthcare costs limit access to essential care and can lead to financial hardship. And secondly, employers. Increased healthcare costs reduce employers' ability to provide competitive benefit packages, and they create challenges in attracting and retaining the talent. Most importantly, as I directly am responsible for the Salinas Union High School District staffing. I strongly urge the hospitals to prioritize patient care over profit and work towards more equitable
2 minutes.
pricing practices. Thank you so much for your time.
Thank you. We just want to encourage members of the public that are making public comment to limit your comments to the agenda item. There will be a general public comment period at the end of the meeting today for all other public comments. Looking to the room, seeing no one at the podium, looking back virtually, Travis West, you're unmuted. Please go ahead.
Hey, thank you. Travis West, Regulatory Policy Specialist with California Nurses Association. First off, I wanted to start by thanking the OCA board and staff for all your hard work. It's just covered in the executive update section. We also wanted to express our concern regarding whether and how OCA determines the prices set by providers in the hospital spending measurement. Specifically, the framework as discussed so far appears to conflate healthcare prices with costs of care. As we understand it, the overall project of OCA is to control spending to make healthcare more affordable. And it's a disservice to that goal in OCA's legislative mandate to base hospital spending measurements on price rather than the cost of care, particularly if these spending measurements are going to be used to set hospital spending targets. Using current prices as a spending benchmark without comparing it to the actual cost of care will essentially lock in the benchmark at already inflated prices. It's important that OCA distinguish how much of the price goes to the actual cost of providing direct patient care or ancillary services and how much is devoted to profit margins, administrative costs, marketing, executive pay, and other factors that are unrelated to direct provision of patient care or related ancillary services. In other words, while current prices and net revenue data may accurately reflect what is spent on care, price and revenue are not a legitimate and accurate reflection of the actual cost of providing direct patient care without determining how much price and revenue data are already inflated. Based on the current discussion, it's not clear how OCA intends to examine how hospitals use their reimbursement rates, whether hospitals are appropriately spending healthcare dollars on the provision of care and supporting the healthcare workforce, whether hospital prices are justified. We strongly hope and encourage that OCA will also establish a framework for examining how hospitals spent their revenues before baking in existing prices as benchmarks for hospital spending. Thank you.
Thank you. Looking in the room, seeing no one at the podium, looking virtually, seeing no hands raised, that concludes public comment, noting for the record that board member Don Molds did join us during the introductory remarks.
Thank you very much. We will move on to our action consent items. Deputy Director Pagani.
We just have the November meeting minutes. They've been circulated with your meeting packet and have been distributed.
Thank you. Is there a motion to approve the minutes?
So moved.
Moved by Rick, and a second? And a second by Elizabeth. Thank you. We'll call the roll.
Dr. David Carlisle.
Aye.
Dr. Sandra Hernandez. Secretary Kim Johnson.
Aye.
Richard Kroenig.
Aye.
Ian Lewis. Elizabeth Mitchell.
Aye.
Richard Pan. 4 yes, 3 absent.
Okay, we'll hold this open for Dr. Pan. Okay. And then we'll come back to public comment on that item as we hold that open. So thank you very much. And we will turn to our informational items now, beginning with an introduction to the behavioral health definition and investment benchmark, including advisory committee feedback. And again, as a reminder, this was held over from the November meeting, and I will turn it over to Margarita Brandt, Assistant Deputy Director, and Debbie Linz, Healthcare Delivery System Group Manager. Thank you.
Good morning, members of the board and the public. Today, I will be introducing our behavioral health investment workstream. I'll review a few introductory slides on OCA's behavioral health spending definition and investment benchmark workstream, and then turn it over to Debbie Lindes, Healthcare Delivery System Group Manager, to walk through the rest of the presentation and share a summary of the feedback from the advisory committee. And then I also wanted to note we have members from the Friedman Healthcare team who are our consultants working with us on this workstream on the line if there are very detailed questions from the board that Debbie and I cannot answer. So if we could go to our next slide, just as we usually do for our focus areas for promoting high value, just to emphasize that we have 5 focus areas. And we're actively working on defining behavioral health for the purposes of measuring spending and setting a benchmark with input from our investment and payment work group and the advisory committee. and that this is the first of several presentations to the board on the behavioral health workstream as we lead up to seeking board approval of a behavioral health investment benchmark. And then on the next slide, of course, our behavioral health investment work is guided by the statutory requirements outlined on this slide. So OCA is required to promote sustained system-wide investment in behavioral health care, and in doing so, measure the percent of total healthcare expenditures allocated to behavioral health and set spending benchmarks. So to complete those tasks, we will need to define behavioral health spending for the purposes of measurement and determine what portion of spending will count towards the benchmark. And this will depend in large part on the priorities for sustained system-wide investment. And OCA's mandate to measure and benchmark spending is a component of our broader system-wide efforts to improve health outcomes in California. And in the case of behavioral health, the statute requires us to promote models of behavioral health that integrate behavioral health with primary care and broader social and public health services, encourage the adoption of alternative payment models that enable improved access and team-based approaches to care, help reduce disparities in behavioral health, and expand access using telehealth and other solutions. So if we could go to the next slide. Here, we just wanted to provide a bit of background in the next two slides on the current status of behavioral health in the state and nationwide. And for many states, increasing focus on behavioral health investment is in part due to the dual pandemic of COVID-19 and the behavioral health crisis that only intensified as a result of social isolation, economic instability, and greater acknowledgement of systemic racism and other factors that were occurring alongside the pandemic. As noted here, nationally and in California, nearly a third of adults report symptoms of anxiety or depression, and unfortunately, we know that too many of these individuals are not receiving appropriate treatment. A CHCF study from a few years ago found that nearly 2/3 of adults with mental illness in California do not receive treatment. The good news is that some evidence indicates that effective treatment for behavioral health conditions, especially in integrated care settings, contributes to better behavioral health and overall health outcomes and correlates with reduced healthcare costs. So if you could go to the next slide. Again, just a bit more context. So this slide shows the distribution of behavioral health diagnoses for emergency department visits and inpatient hospitalizations in California in 2021 using data from HCI's patient discharge and emergency department hospital encounter data. For the year 2021, there were nearly 1 million emergency department visits and close to 900,000 hospitalizations in California, with a mood disorder or anxiety listed as the primary or secondary diagnosis. And substance use disorders, including alcohol, stimulant, cannabis, opioid, and other substance use related disorders, were listed as the primary or secondary diagnosis for over 1.3 million hospitalizations and emergency department visits that year. So altogether, mental health and substance use disorders, including co-occurring disorders, were present on 27% of all California emergency department and inpatient encounters in 2021. And this indicates that consumers are accessing the emergency department and inpatient care for behavioral health conditions that could be more effectively cared for in outpatient and community-based settings. So if we go to the next slide. Again, here wanted to share part of our work is, of course, working with our investment and payment work group to develop the behavioral health definition and investment benchmark proposals. So we have been meeting with the investment and payment work group for more than a year every month. These are the members of the work group, which advises both, as you know, on our primary care and alternative payment model work, and now our behavioral health work. And the members highlighted in light blue have recently joined the work group to support our current focus on the behavioral health workstream. So we added several new members, and some members transitioned off as we wrapped up our work on primary care and alternative payment models. And you'll note that just work group members represent a range of expertise, including providers, health plans, hospitals and health systems, consumer representatives and advocates, academics and subject matter experts, and our fellow state and private purchasers. So on the next slide, here I'll turn it over to Debbie Lindes, who will walk through our work to develop a framework for measuring behavioral health spending. Debbie Lindes is our healthcare delivery system group manager, and she'll provide an overview of the framework and our initial thinking on an investment benchmark.
Thanks, Margaretta. Good morning. I'm Debbie Lindes. I use she, her pronouns, and as Margaretta mentioned, I'm the manager for the Healthcare Delivery System Group within the Health System Performance branch at OCA. Under Margaretta, I lead our work on primary care and behavioral health investment, as well as workforce stability standards, and I'm happy to be here today to introduce you all to OCA's behavioral health investment work. I'll start by providing some national context for our discussion. Across the United States, approximately a dozen states measure behavioral health spending. 9 of these states measure behavioral health spending within primary care, as highlighted in light blue on the map. These 3 states, shown in dark blue, measure behavioral health spending across the full care continuum. California will join those other 3 states to measure behavioral health spending across that full continuum of care. Can I have the next slide? So this slide reviews OCA's key use cases for behavioral health spending measurement, which will inform how we structure our behavioral health spending definition. As required by statute, OCA will measure behavioral health spending as a percentage of total healthcare expenditures, or THCE. As part of that measurement, OCA would like to understand spending on both mental health care and substance use disorder services. It would like to understand the distribution of behavioral health spending across different types of services and care settings, including primary care. And finally, OCA proposes to establish a focused benchmark for behavioral health spending that supports statewide goals and priorities. And we'll discuss this further in a few minutes. Some analyses, such as understanding the portion of THCE spent on behavioral health services in an outpatient setting, may be best served by OCA's data collection. Other, more complex analyses may be best served by the Health Care Payments Data Program, or HPD. Next slide, please. The graphic on this slide is adapted from a recent Milbank Memorial Fund report cited in the footnote, which was authored by our colleagues at Friedman Healthcare. In alignment with statute, OCA is focused on measuring spending for those services that are part of total healthcare expenditures, which are clinical services paid for by public and private payers through claims and non-claims payments. We recognize that this is a relatively narrow view of behavioral health spending. In the future, OCA will explore the possibility of using supplemental data sources, such as some of those shown in the other quadrants of this graphic, to capture other spending. In particular, we want to acknowledge the significant direct spending by consumers for behavioral health services. While OCA's current data sources will not be able to quantify this spending, OCA does plan to study out-of-pocket, out-of-plan, or self-pay behavioral health spending as part of a separate work stream. We will collaborate with the out-of-plan spend measurement team to ensure that insights are shared across those work streams. Next slide. So this slide presents a high-level equation for measuring behavioral health spending, and it looks familiar to you all, I'm sure, and very similar to the equation you've seen for measuring primary care spending. The numerator includes claims and non-claims-based payments for behavioral health care. This numerator is then divided by the total of all claims and non-claims-based payments, or total medical expense, and the quotient is multiplied by 100 to arrive at behavioral health investment as a percent of total medical expense. Of note, the numerator will include patient out-of-pocket responsibility for behavioral health services obtained through the plan, in other words, services for which a claim or encounter was generated. The denominator will include pharmacy spending and all patient out-of-pocket responsibility for services obtained through the plan. Much of the investment and payment work group's effort will focus on developing recommendations for what to include in the claims-based and non-claims-based payment components of that numerator. Next slide. So similar to the approach for measuring primary care, OCA proposes to use 3 modules to measure behavioral health spending. And these are behavioral health care paid via claims and non-claims, and thirdly, behavioral health in primary care. The behavioral health and primary care module will be measured separately, so it can be included in analyses of either behavioral health or primary care spending. For the purpose of measuring behavioral health investment as a percentage of total healthcare spending, this module will be included as behavioral health. OCA initially defined this module with input from the investment and payment work group as part of its primary care work. Over its next few meetings, the work group will inform OCA's development of the behavioral health care paid via claims and non-claims modules, and it will also weigh in on whether any adjustments should be made to the behavioral health and primary care module. And before we move on, I want to point out one potential important difference between our approach to behavioral health versus primary care investment, which is that while we will measure overall spending on behavioral health care, our investment benchmark may focus on a subset of conditions, care settings, or populations that are a high priority for increased investment. Unlike primary care, which occupies a specific place in the healthcare continuum, behavioral health care treats specific conditions across the entire continuum. Increases in some types of behavioral health care may serve OCA's goals more effectively than others. A more focused benchmark for behavioral health spending would acknowledge this. And again, we'll discuss the benchmark more in a few minutes. Next slide, please. OCA proposes a phased approach to defining and measuring behavioral health spending. Our initial measurement and data collection will focus on the commercial and Medicare Advantage markets to reflect OCA's data collection approach. The next step will be to adapt the commercial market definition to the Medi-Cal market, possibly including data sources specific to Medi-Cal and making refinements as needed. And of course, we will revise the definitions over time as we learn from experience. Next slide. So currently 3 states, Maine, Massachusetts, and Rhode Island, have defined behavioral health for the purposes of measuring spending. Additionally, the Milbank Memorial Fund has published recommendations for a standardized definition with input from states and other experts. And this slide shows how these states and the Milbank recommendations approach some key decisions OCA will need to make in developing its measurement definition. Claims payments include information about diagnoses, care settings, and providers, among other things. Each of these elements can be considered in defining an expenditure as behavioral health or not. All 3 states restrict their behavioral health definitions by diagnosis, and no state limits to only certain providers. States take differing approaches to whether and how they categorize care by care setting. For example, Massachusetts uses a combination of services and care settings, such as inpatient, emergency department, and outpatient, to categorize care delivery. Next slide. And here's a high-level overview of the considerations and trade-offs associated with these 3 key decisions, starting with restricting by diagnosis. As a reminder, all existing state behavioral health definitions do restrict by diagnosis. And restricting by diagnosis can be helpful because it's necessary if we want to measure substance use disorder and mental health spending separately. It's needed to capture spending by non-behavioral health clinicians, like primary care providers, and in non-behavioral health care settings, such as the emergency department or acute care hospitals, where many services are for non-behavioral health care. It's also needed for measurement of any benchmark that focuses on specific diagnoses. On the other hand, including diagnosis codes in the definition for behavioral health does not align with OCA's approach to measuring primary care. But it's helpful to keep in mind that primary care spending measurement tracks spending on a set of services provided by a set of providers. And this is different from behavioral health spending measurement, which tracks spending associated with care to treat specific conditions or diagnoses. Given these differences in purpose, the difference in approach may make sense. The second key decision for determining our approach to measuring behavioral health claims spending is whether to categorize services by care setting. Massachusetts and the Milbank Memorial Fund categorize behavioral health spending by care setting. And doing this provides opportunities to monitor and report on spending in specific care settings of interest, such as services provided via telehealth or in a residential setting, for example. Maine tracks care delivered via telehealth, but does not categorize spending by care setting otherwise. And the final key decision is whether to restrict by provider type. To do this, OCA would need to develop a list of behavioral health provider taxonomies. One option could be to use taxonomy only when identifying behavioral health spending in primary care. And the Milbank definition uses primary care provider taxonomies to help identify behavioral health setting in primary care. The Milbank Advisory Group also noted that all payer claims databases, such as California's HPD, could be used to conduct analyses of behavioral health care delivery by specific provider types. Each of these decisions comes with follow-up questions that OCA and stakeholders will need to consider in developing a behavioral health definition that includes restrictions based on diagnosis, care setting, and/or provider type. Next slide. So OCA will collect data to measure behavioral health spending from the same entities that submit data for measuring total healthcare expenditures, or THCE. OCA statute requires that behavioral health be measured as a percentage of THCE. And as I mentioned a few minutes ago, THCE measurement captures spending by payers and patient out-of-pocket spending through deductibles and coinsurance. Other spending in support of behavioral health care and related services, such as out-of-plan spending by consumers and state budget financing, is not included in OCA's current measurement scope. Behavioral health spending data will include both claims and non-claims payments, with non-claims payments organized into the expanded framework categories. OCA will develop definitions and technical specifications for the submission of behavioral health spending data and will offer technical assistance to support accuracy and consistency. This will be particularly important for the non-claims portion of spending. And OCA's initial efforts at measuring behavioral health spending will focus on commercial and Medicare Advantage payers and their members. Next slide. So now I'll spend a few minutes providing an overview of OCA's work thus far related to setting a behavioral health investment benchmark. Next slide. This slide shows OCA's proposed goals for improved behavioral health care. We want this care to be accessible, comprehensive, coordinated, equitable, and of high quality. These goals were adapted with input from the Investment and Payment Work Group from a policy brief released by the California Health and Human Services Agency. The work group plans to refer to these goals as touch points as it continues its discussion of behavioral health investment priorities. Next slide. So here we have a logic model we developed to illustrate OCA's role in improving behavioral health outcomes through its measurement and benchmarking activities. Our work supports other stakeholders' actions, which we hope will result in achieving the system-wide behavioral health goals. Starting on the left, we see a two-way relationship between the system-wide behavioral health goals from the previous slide and California stakeholder actions. In one direction, the system-wide goals motivate stakeholder actions, which should in turn result in movement toward the goals: more accessible, comprehensive, coordinated, equitable, and high-quality behavioral health care. On the right, we see OCA's role in the model. The measurement, public reporting, and benchmarking that will come from OCA give California stakeholders information and analysis to support their actions in pursuit of the system-wide behavioral health goals. Next slide. And here are just a few examples of how those interactions might work. OCA could measure and report mental health and substance use disorder spending separately to show differences in spending between these categories and compare it to the need as identified by prevalence data from other sources. OCA could measure and report spending across service categories to highlight the need to rebalance care toward outpatient care and prevention. And OCA could recommend benchmarks for increased behavioral health spending for specific populations, services, or care settings that would motivate stakeholders to invest more in these areas and move the behavioral health system toward the goals. Next slide. So this slide lists some of the key decisions that OCA will need to make with input from the Investment and Payment Work Group, the Advisory Committee, and the Board. For example, the work group has begun and will continue to discuss priorities for measuring behavioral health spending and will provide input on the phased approach to measurement. The work group has also done some early work on defining principles for the benchmark because decisions about the focus of the benchmark will have implications for the definition of behavioral health spending that OCA will measure. We will also consider decisions around the components of claims-based spending. This conversation will include which diagnoses, services, providers, and care settings OCA may include in a definition of claims-based behavioral health spending, as we reviewed a few moments ago. And OCA will also need to define non-claims spending. The key decisions around benchmarking will include whether to increase behavioral health care spending across the continuum of care or to focus on particular conditions, care settings, or populations based on priorities for increased investment. And then the work group, advisory committee, and board will weigh in on defining the benchmark level and a timeline for achieving it. Next slide. So as our statute requires, OCA will measure total behavioral health spending as a percentage of healthcare expenditures. This measurement allows OCA to report overall behavioral health spending at a given point in time. In contrast, the benchmark is more of an instrument for achieving policy aims. It's an opportunity to focus attention and effort on a desired outcome. For example, an increase in the relative amount spent on outpatient and community-based services. Based on discussion with the Investment and Payment Work Group so far, OCA is proposing a behavioral health investment benchmark that includes some, but not all, behavioral health spending. After developing an approach to overall measurement, OCA will gain additional input from stakeholders, including the work group, advisory committee, board, and public comment on a proposed benchmark before bringing a recommendation to the board for adoption. Next slide. And now I'll review an example of a state behavioral health investment benchmark to demonstrate how another state has chosen to focus their benchmark. Rhode Island's Office of the Health Insurance Commissioner, or OHIC, has set a behavioral health spending obligation that focuses on spending for community-based behavioral health care for fully insured children and adolescents aged 0 to 18 who are covered by commercial carriers. The decision to focus on community-based behavioral health care for children and adolescents was made due to a high prevalence of behavioral health conditions in this population. Rhode Island's spending obligation, or benchmark, requires carriers to increase their per member per month spending in 2025 on community-based behavioral health care for the target population to 200% of a baseline level based on calendar year 2022 spending data. This benchmark is not as daunting as it might sound because the targeted spending, community-based care for children and adolescents, is low relative to total healthcare spending and even relative to total behavioral health spending. For example, if the spending at baseline were 50 cents per member per month, the benchmark would require commercial payers to increase that to $1 per member per month over 3 years. After 2025, carriers whose spending for the target group during the most recent measurement year falls below the market average must increase their spending to reach the market average as determined by OHIC. The measurement will include claims and non-claim spending for community-based behavioral health care and only applies to spending for residents of Rhode Island who receive care from providers located in the state. If carriers don't meet the benchmark, they will be subject to penalties determined by the commissioner. Next slide. So here we have our tentative timeline for the behavioral health work. We plan to meet with you again to report on our progress in January and February of 2025, with an interim update for the advisory committee earlier in January. We will again seek advisory committee feedback in March and come back to you for further input in April. OCA currently plans to bring a recommended behavioral health investment benchmark for board consideration and approval next May. If needed, we may adjust the timeline along the way, and we'll aim to give as much advance notice as possible for any changes. Next slide. So we wanted to share the feedback we received from the advisory committee, which we presented a similar introduction to behavioral health to the advisory committee in late October. We received suggestions to engage additional stakeholders, such as clinical professional organization representatives, behavioral health providers not in managerial roles, emergency medical services personnel, and people with lived experiences of behavioral health conditions. Committee members had questions on how diagnosis codes will be used to measure behavioral health care. Several committee members discussed the behavioral health and primary care module, including questions about how the module will be defined, concerns about the availability of primary care clinicians trained to provide behavioral health services, and concerns that care management and care team infrastructure may not be adequate to support behavioral health needs. On the work overall, members noted that prevention is important and that not all behavioral health care is provided through the medical system. Members also cautioned that more behavioral health spending, such as through institutional care, does not necessarily lead to better outcomes. Members highlighted that it's important to capture behavioral health spending via telehealth and spending under capitation, and that access to care is critical, especially with a focus on therapy, peer support, wraparound services, and other community-based services. And lastly, members identified affordability as a goal for measuring and benchmarking and noted that out-of-plan spending is important to consider. We're actively incorporating this feedback from the advisory committee into our work and discussions with the investment payment work group. And I'll pause here to see if Rick Kronik has anything to add or expand on for the advisory committee feedback, and then open for questions and discussions from the board. Thank you.
Nothing to add, Debbie. I think you did a good job of summarizing the advisory committee input.
Thank you very much for the presentation. I also want to acknowledge Dr. Pan has joined us. And good morning. And I'll turn to questions from the board. David.
Well, thank you. I thought that was a great presentation, Margareta. Debbie, thank you very much. A broad question, and thank you for the information on the Rhode Island experience. I was wondering what more we know about the other states that are involved in this area, especially the other three that are taking a deeper dive, and do they have departures that are significant from the methodology that we're adapting? Number one, and probably number two, maybe not enough time has passed to give us a good amount of feedback on this, but do we have lessons learned from these states as well that are relevant to us?
Sure. So I can start and then welcome Mary Jo Condon from the Friedman Healthcare team to weigh in, and Debbie as well if she has any thoughts. So there are 3 states that are measuring behavioral health spending, but Rhode Island is the only state so far that has introduced a benchmark or an obligation. So they are the only state that has that obligation that Debbie walked through. In terms of the measurement from the other states, we are starting, using those other state definitions as a starting point for our discussions in the investment payment work group in terms of how we define behavioral health spending. So we'll be looking at the Massachusetts definition, the Rhode Island definition, and I'm forgetting the other state, Maine. And then also the Milbank Memorial Fund, they brought together a bunch of states and that both have their definitions already, and we participated in that advisory group as well to develop recommendations from a group of cross-state representatives that participated in that Milbank Memorial Fund report. So we are relying on those current definitions and the recommendations from Milbank as our starting point, and we'll explore, whether our investment and payment work group would like to make different adjustments or different decisions related to those areas.
Is there a lot of variance among the states, across the states in definitions, or a lot of consistency?
There seems to be a fair amount of consistency, but I'll let Mary Jo, if she wants to weigh in on some of the differences. There are a few differences, but most of the states, as Debbie noted, start with diagnosis and focus on diagnosis as the starting point for measuring behavioral health spending. Mary Jo, is there anything you want to add?
Sure. Yes, I think that's absolutely right. There is a lot of consistency across the states. There's two areas of diagnosis where there is some difference. So, really three, but two that I think matter more in terms of the amount of impact on spending. So, one is whether or not to include diagnoses related to dementia. And the other is whether or not to include diagnoses related to autism and other developmental disorders. And so the investment and payment work group is actually going to be talking through that question along with some others during its next meeting, which is later this week. There are other slighter differences in the codes that are included, but most of the states have a lot of consistency in the service codes, place of service codes that are included.
Dr. Penn, and then we'll go to Elizabeth.
Thank you very much for this presentation. Certainly creates a good framework for us to look at things. A few questions here. So first of all, in terms of the total behavioral health spending, I know you're starting with commercial and Medicare Advantage, and I can see the reasons for that. At what point do we start folding in Medi-Cal, which is a third of all, and it's half, by the way, it's half of all children. So it's a third, and of course, a major mental health provider, as well as actually interesting enough long-term care, because if we start talking about dementia, you start thinking, then there's an interface there too, right, as well. I mean, the reason people need long-term care, that's the only reason, but that becomes a significant reason and a significant cost as well. So so in terms of where Medi-Cal fits in all of this, when do you see that being incorporated?
So we are aiming to incorporate that as part of our work to collect data from the Medi-Cal managed care plans. And I'll note that we are actively working with DHCS to talk with them and developing a definition with them that is specific to Medi-Cal. So we're actively having conversations with DHCS about all their different sources of funding and the behavioral health coverage in the Medi-Cal program. So aiming to incorporate that as we start collecting data from the Medi-Cal managed care plans.
Yeah, and I think many of us are familiar with the fights about mild and moderate versus severe, and Hoots County behavioral health responsibility versus the Medi-Cal plan responsibility. So, of course, all that has to be sorted out as well, or actually captured in the behavioral. The other part is that I certainly agree. You have the slide where you talk, the big circles, the total, and then you have the benchmark, because you got to think about the distribution of spending within behavioral health, right? So, as you mentioned, institutionalization isn't necessarily a success, although perhaps required, and but yet that's probably going to be the bigger portion of the spend. So, if we just sent an overall benchmark, we may actually give an incentive for the wrong thing. The other issue that I think we need to think a little bit about, I presume we're sending a benchmark that's going to be higher than the current spend, but it's a benchmark can be sometimes can be a cap depending on how we do this. But the other part is that hopefully one of our goals as we're trying to do this is that behavioral health, access to behavioral health services becomes higher or better in commercial plans, Medicare Advantage, and then hopefully in other parts of the system. And there are probably a substantial portion of people who are essentially paying out of pocket, right, cash for their behavioral health. If you ever tried to find a therapist, it's a lot of people end up finding out the networks are very narrow and they end up paying out of their own pocket. And there may be a shift of people from that category, which we're not measuring, or it's difficult to measure, toward and figuring out. So as we do the benchmark, we got to think about what does that really mean, right? And in terms of that, is it a shift or is it actually better? I mean, it's better access through the plan, but it's exactly what's happening there. The other thought I also had in terms of particularly for children being pediatrician and someone who actually has a focus on developmental pediatrics and takes care of a lot of kids with things like ADHD, and which is usually defined as a mental health issue, is the role of schools and mental health provided through schools as well. Actually, frankly, part of, I won't say my dream, but I hope that plans will consider actually contracting with behavioral health professionals in school districts. Now, school districts aren't always set up those kind of contracts, but in terms of availability of the service and also sometimes even privacy, right? So if it's one thing, you have to have your parent go and find a therapist for you, and when that happens, the therapist won't tell the parent, but the child's kind of an awkward position about things they're sharing. But the school setting may, or the parent may be in denial, let's just be blunt, and sometimes not go and seek out those services even when the child wants it, but oftentimes the school is a great venue to be able to have that kind of support. So not to make things more complicated, but I mean, it is a thought in terms of you're trying to improve, one of the goals is equity and access and so forth, and if we're moving the Medi-Cal patients out of the way, and by the way, this is still an issue for even Medi-Cal, then you may want to think about how do you capture and, if plans do contract, let's say, with non-healthcare entities like schools, that we recognize that as well. So probably not something that's happening on a big scale, or it's probably only a very small scale right now, but maybe something we want to encourage as well for plans to consider. And so anyways, there's some thoughts in terms of how we make our benchmarks actually work toward getting the goals that we want. I think that's ultimately what we're trying to do, is how do we shape the benchmark in a way to give the right incentives for the payers that we're benchmarking to actually not just throw more money at it, but actually direct the money in a way that's most effective to get people behavioral health.
Thank you for those comments. And I also just mentioned that on the healthcare services side, the fee schedules, is happening right now on with schools and some of the Children and Youth Behavioral Health Initiative components. So that will become more of a pathway as that grows. So appreciate you lifting that up. Elizabeth.
Thank you, and thank you for the presentation. I'm glad we're taking this on. I have two questions, perhaps. So in the commercial side, there is so little access to behavioral health. Even if they have coverage, they can't often find anyone. There are ghost networks. There's major problems with access, even when there is coverage. And so employers are now, and purchasers are now sort of almost duplicating their spend on point solutions, private companies who are trying to do this a lot by telehealth. I saw that in the advisory committee feedback. So I just would want to make sure we are also capturing all of that spend because it's significant. And then separately, I don't know if this will, I don't know how doable this is, but the number of hospitalizations and ED visits for behavioral health are just pretty shocking. And I'm guessing those are being driven by lack of access to more appropriate settings. So will there be a way to look at in the benchmark, maybe it's, maybe the amount is okay, but it shouldn't be going to EDs, it should be going to where it's needed. So will we have the ability to sort of calibrate, because right now we may be I don't have any idea, we may be spending enough just in the totally wrong place. So how will that be tracked?
Sure. So many of these points have been discussions in our investment and payment work group, and one of the initial, discussions or thinking we've had around the benchmark is potentially focusing on community-based and outpatient services that are in network to increase investment and shift resources towards that outpatient community-based services. So that has been one consideration, and so potentially that's one approach to the benchmark while also measuring total behavioral health spending. And then also we've had a lot of discussion about what are some supplemental analysis that we could do either in OCA's data collection or through the healthcare payments database. So we are trying to think about how do we measure the spending that's happening currently, how do we set our investment benchmark potentially as a subset of that total spending, and then what analysis do we do to supplement the spending analysis to track how the care is being provided. So those are all discussions we're actively having in the investment and payment work group. Rick?
Thank you. Thank you, Debbie and Margareta. Very helpful. Couple of exhortations and then a couple of questions. Following up on Richard's comments, I mean, I do think, you know, the getting Medi-Cal into this is really, really, really important. And I heard Richard's question, and Margareta, you gave a good answer, but didn't quite answer kind of the when, and you may not be ready to do that now. But the exhortation is to move on as quickly as you can. And I'm glad Secretary Johnson is here, and I'm sure we'll encourage DHCS to kind of work cooperatively on doing this. I mean, it's important for THCE as well, which I know, you know, is part of the broader conversation, but much more important in behavioral health. Second exhortation, excuse me, which I know you heard from the advisory group and from us previously, is around the out-of-pocket, out-of-plan. It's been brought up again, and you mentioned there's a separate work stream on that. It would be, you know, good to prioritize and try to push that along, which I know is difficult. Two questions. I wonder why in baseline you've got commercial and Medicare Advantage, but not traditional Medicare. And I know that we're primarily collecting data from insurers, which is Medicare Advantage, but you do have access, I think, to the traditional Medicare claims. And could do, you know, parallel analyses on those claims, I would think. Although I see the puzzled looks, and maybe the answer is not. And then second, on slide 29, there's a, you know, set of key decisions. I'm wondering, will we, when we come to May and be asked to vote on benchmarks, will we have estimates of status quo? Will we have some estimates of how much is being spent in various settings today? Is that kind of part of what we're work stream?
So I can speak to the estimates, and I don't know, Vishal, if you want to speak to our traditional Medicare data collection process. So for estimates of current behavioral health spending, we are actively working with civilian state departments like Cover California and CalPERS to try to see if we could run a behavioral health spending analysis using their claims and encounter databases, and also exploring whether that's possible through the HPD. So we are actively working on both of those work streams. We don't have an estimate of when that spending analysis might be available, or, you know, how long it might take us to get that analysis ready to share, but we are currently working to do that.
Yeah, Rick.
I had two things to add, which may or may not be helpful. The first is that I think it would be important as we're doing this to articulate the reasons why we're doing this. So, and that is not to say that this is not an important area that I think it's hugely important. But there's so much in behavioral health, and there's so many reasons for focusing on it. And I think depending on which reasons we're focusing on, it probably drives some differentiation. You're, I think, rightly identifying a need to start thinking about what sorts of care we're wanting to track and have spending benchmarks for, and what maybe not. And Richard suggested that maybe some are counterproductive. But you know, there is, just to name a few, there is the underdiagnosis and treatment of depression and its relation to chronic conditions. There's the undertreatment of severe and persistent mental illness and its relation to all sorts of other things, many of which are expensive, you know, including unnecessary hospitalization, et cetera. But so I think that may help with the differentiation, if that we force ourselves to do the hard work of asking the question, what are we trying to accomplish here? That's one. And then the second, you had alluded to the request that you made of us and to cover it about spending data. And so just not to throw out a spoiler, but one of the things that we've seen in our own data that I think will make this somewhat more complicated is that with the pandemic, we saw this massive increase in behavioral health utilization. We have seen some of that use stay much higher than it was pre-pandemic, and some of it come back down to closer to normal range. We honestly do not know what is appropriate and not appropriate, whether it was how much of it was generated by so anxiety and depression. Treatment went through the roof during COVID. We don't know how much of that was situational, how much of that was under diagnosis. The fact that it has stayed high suggests that it was situational, resulting in sort of an identification of underdiagnosis, and so it stayed high for that reason. But some things have come down, and the reason I raise that is that at some point, as we think about benchmarks, it's going to be really hard to figure out the appropriate one here, and there's going to need to be a certain amount of fluidity in it, which is sort of counter to the notion of a benchmark in the first instance. But if we aren't able to kind of work through some of those issues, if we had come up with a benchmark for anxiety and depression pre-COVID, that might have been wildly wrong. We come up with one at this point in history, it might be too high. We just don't know. And I don't know how we get to that, but we're going to have to do a decent job of getting to that, or this isn't going to be that meaningful. So that's another one just to kind of throw out to think about as we move forward.
Thank you. And just let me go to Vishal, and I'll come back here, and then we'll go to Richard. Did you have one?
Yeah, I was just going to return to Rick's question about Medicare fee-for-service. So we have gotten some total medical expense data. It is aggregated. They'll have professional services. It won't be necessarily broken out by behavioral health. But then we also, the HPD is also collecting fee-for-service claims data. So we'll have to kind of take a look at that to see kind of what makes sense, whether, CMS has data directly, or we need to kind of compile it ourselves using the claims data.
Just building on some of the comments that the members have made, I also just say this is a place, right, we really are changing landscape. We're transforming behavioral health in California. And so to the extent we are thinking about, I think to your last comment, Don, fluidity, I think we have to take into account the investments in primary and early intervention that are happening through Proposition 1 and behavioral health, but kind of the timing and sequencing of these things going forward. Dr. Pan mentioned some of the pieces that are also related to schools and children and youth behavioral health initiative, et cetera. So, and of course on the Medi-Cal side. So just again, it might be helpful for us to be looking at the time horizons of some of those changes and also engaging some of the other departments leading some of those efforts and getting specific to that area. Richard.
Thank you. I guess the other thing I just want to mention, and trying to think about how this fits in terms of our benchmark, even as we are doing our primary care benchmark, in many ways I think a vast majority of mental health conditions are usually chronic. I mean, there's certainly kind of acute issues with mental health issues that then resolve, but and so there's some similar themes with, for example, we talked about in primary care that really where the money is, right, is actually in the potential savings is about better coordination of care and getting ahead of things and prevention and so forth. And I think there's going to be some parallels in terms of behavioral health too. I mean, we do have perhaps, we probably have underdiagnosis and lack of access, but for the people who actually do have access, by whatever means. The question is that things like continuity, things like having continuity. So imagine you have to change a provider every year because this plan has this network, or they had different contract, et cetera. And that actually can be more expensive, right? Because now you're repeating your story again, that person knows you, et cetera. So, so as we're trying to develop the behavioral health benchmark, there may be certain themes that cut across both the primary care and the behavioral health benchmark in terms of trying to achieve like our ultimate goals, right? These benchmark isn't in itself, but in terms of, improve access, equity, all the other things that we had on that other slide. So I just want to throw that out there for something to think about as we're doing benchmarks on both. And how do these benchmarks then drive ultimately, more affordability and better quality, which is certainly our goal.
Great. And just a shout out and appreciation for the logic model that was included in there. And I think to Don's comments, to the extent that we even want to maybe unpack it another layer further in terms of the accomplishments, that might be helpful going forward. Very much appreciate the conversation. Looking back to any other members, not seeing any, we'll open it up for public comment. Thank you.
We'll now take public comment on this agenda item. If you'd like to make a comment, please step to the podium. If you're attending virtually, please raise your hand. Please keep your comments limited to this agenda item. We will have a general public comment period at the end of the meeting. And if possible, please limit your comments to 2 minutes. Looking to the podium, go ahead.
Beth Capel for Health Access. First of all, to acknowledge how much this administration has done in behavioral health, and to say that the reason that this is in the OCA law alongside primary care, literally in the same article, is because those of us who helped craft the law understood how gaping the unmet need is. And I want to take you back to a couple of the slides that we've looked at. On slide 12, it says 1/3 of adults have mental health issues, but 2/3 of them don't get care. That right there is a measure of failing to meet the needs. On slide 18, you had a pie chart that suggests that a chunk of the spending is done through health plan, through in-network care. I would submit to you, we don't actually know today how much of the need that is being met through in-network, in-plan spending. And then when we look at the other sources of mental health, and Dr. Pan pointed to some of them, whether it's county behavioral health or parts of the Medi-Cal program, we have many more things to get our arms around. The law requires you to measure the spending on total healthcare expenditures and as a subset of total healthcare expenditures, and that's obviously a place to start, but it is far from sufficient. I would say the discussion you've just had, like the discussion in the work group and in the advisory committee, betrays a lack of agreement on what the appropriate place to get to is. And I'm just going to give you a few of the examples because it's been an interesting process. It's so very different than primary care. Primary care, we knew where we wanted to go. We knew what a well-functioning health system looked like. There were minor disagreements about things like retail clinics, but on behavioral health, there is no similar agreement. We've had disagreements about whether it's more appropriate to focus on upstream spending or urgent and unmet need today. It very much reminds me of the conversations we used to have about the uninsured. We have disagreements about whether there's an adequate behavioral health workforce or not. Some assure me there are sufficient providers, they just don't happen to be in network. We have disagreements on whether we need more spending or just better spending, better allocation of spending. So I think your conversation reflected those discussions, and I think I'm glad we did primary care first because this is a much more challenging assignment. And those of us who included it knew it would be a more challenging assignment. So thank you.
Thank you. Looking virtually, Mia Cooper Khan, I see your hand raised.
Hi, yes, thank you for this presentation. My name is Mia Cooper Khan. I'm the Senior Manager of Behavioral Health at Alameda Health Consortium, the network of 8 federally qualified health centers in Alameda County providing integrated behavioral health and primary care. Collectively, we have over 120,000 behavioral health visits per year, mostly Medi-Cal. I just wanted to flag that it's important to note among the states identified as examples for other state approaches to defining behavioral health, all 3 allow for same-day billing for mental health and behavioral health services when delivered in federally qualified health centers, and California does not. This puts federally qualified health centers like our 8 members here in Alameda County at a disadvantage because we cannot receive reimbursement for the provision of mental and behavioral health services when delivered on the same day as a medical visit. And this should be, I think, part of the board's consideration. We encourage the board to recommend authorization of same-day billing for mental health services and community health clinics to capture the true cost of provision of mental and behavioral health services delivered in primary care settings. And also I wanted to add, as this body determines which data to consider, we also encourage review of MHSA spending plans to project cuts in prevention and early intervention mental health services anticipated to occur due to the change in spending authorizations with the implementation of Prop 1. We believe that the projected reduction in preventative and early intervention mental health services in Alameda County alone due to Prop 1 contradicts the Healthcare Affordability Board's recommendation to increase investments in primary care. For example, here in our network, a preliminary economic analysis of care coordination provided by MHSA-funded integrated behavioral health and other care coordinators in FQs, we identified a $266 reduction in total cost of care per patient touched by these care coordinators. So that's all I wanted to share. Thank you for the time.
Thank you. Look into the podium.
Here, that thing that's working. Thanks for the discussion today. First, we agree with several board members' comments on the importance of incorporating Medi-Cal spending into this work stream. As Board Member Pan indicated, this would involve not only the Medi-Cal managed care plans, but very importantly, the county behavioral health plans as well. So certainly encourage them to be included in these conversations. And just note that incorporating Medi-Cal spending would ultimately likely have some important interactive effects into what that investment benchmark should be, changing that baseline. Second is agree wholeheartedly that access to behavioral health care is insufficient here in California, and that this is true across the full continuum of care. Policymakers have repeatedly acknowledged this fact, and as a result, California is implementing various policy reforms to improve our systems of care, including taking advantage of new federal funding opportunities, investments in infrastructure through the B-CHIP program, strengthening behavioral health parity laws, and so forth. All these efforts recognize the need to expand the full continuum of care, including services provided by hospitals and residential care providers. And the setting of this behavioral health care benchmark represents a critical opportunity for OCA to align itself and ultimately support these broader state efforts to expand access rather than working potentially at cross purposes. And so to do so, OCA should reflect the full continuum of clinically appropriate behavioral health care services in its investment benchmark. Thank you.
Thank you. Looking virtually, Travis, I see your hand raised. You are unmuted on our end. Go ahead.
Hi, thank you. Travis West, Regulatory Policy Specialist with California Nurses Association. We encourage OCA to include money invested in behavioral health training and preparedness at general acute care hospitals as included within the behavioral health definition and counting towards the behavioral health benchmark. As discussed in today's presentation, behavioral health spending accounts for a sizable percentage of hospital visits. Patients often present at general acute care hospitals with a behavioral health condition, but seeking treatment for a separate physical condition. Having nurses or other staff that are trained in the provision of behavioral health care in these non-behavioral health settings helps to ensure that such patients receive the behavioral health care they need when seeking acute care in a hospital. This also protects healthcare workers and patients by preventing workplace violence that may be related to unmet behavioral health needs or iatrogenic responses when hospital staff are not appropriately trained to care for patients with behavioral health conditions. Money spent on training RNs and other hospital staff on how to respond to patients with behavioral health needs is therefore a crucial investment in the overall behavioral health infrastructure and should count towards the investment benchmark. Likewise, acute care hospital investments in procedures and practices for responding to behavioral health incidents, such as behavioral health emergency response teams that are trained and available to respond to behavioral health emergencies as rapid response teams, should also count towards the investment benchmark. Thank you.
Thank you. Looking to the podium, seeing no one at the podium, seeing no hands raised virtually, noting for the record we have about 100 virtual attendees. That concludes public comment on this item.
Thank you for a robust discussion that will be continued, and very much for the presentation and materials put together. I'm going to return to item 3A, which is the approval of the meeting minutes, and turn to Richard to see if you have any questions or related to those minutes.
Oh, actually a couple of small but I think important changes to the minutes. Sorry, let me pull them up. So one, there was noted in the minute, there was a comment from one of us that covered California was under 1%, but it said recently, and actually that and I think why I noted is because we were discussing potential changes given the federal administration change that actually happened during the previous administration. So I just want to be sure that's actually reflected, because it's not the last couple of years. It was actually during a period of time when the state actually responded to changes at the federal level, and because of those policy changes, we were actually able to keep the. You don't have to write that all in there, but instead take out the recently and said during the last presidential administration, perhaps is the best way to frame it. So just to be sure that's accurate. And then there was another place in the minutes where documented a comment that was again made by a board member. I won't identify who, but probably myself. About sort of Medicare and the disparities in not so much disparities, but it really was related to the geographic description. Distortions in Medicare. So it's just, just acknowledging the fact that sometimes what happens is we set policy, decades ago, and for various reasons, for example, it's actually because of cost neutrality. It becomes expensive to adjust to reflect the reality of the current time. So I'm less concerned about, because that technically the statement wasn't inaccurate, it lacked some detail. I don't know if we want to add that or not, but I do want to correct the statement about covered California, because I don't want anyone to think that was referring to the last 2 years, because that would not be accurate. Thank you.
Would you prefer that we actually take the minutes up next meeting and work with the staff on the corrections, at least on that first?
Sure, yes, yeah. And I think we could make it quite simply. In fact, actually, maybe even during the lunch break, we could fix it and then we can approve it. And yeah, because I think it'll be a very small change.
Okay, we will table that then. Thank you very much for those additions. We're going to go ahead and take a short lunch break. I'm sorry, we're going to take public comment on the minutes, but then come back with that item. Any public comment on item 3A, meeting minutes from November?
Please step to the podium. If you're in line, please raise your hand. Seeing no hands raised and no one at the podium. That concludes public comment on this item.
Okay, thank you. Not seeing any changes. We will return and resume at 12:20. 12:20 p.m. we'll resume. Thank you so much. Good afternoon and welcome back. I'll ask for a roll call as we resume.
Thank you. Dr. David Carlisle.
Present.
Dr. Sandra Hernandez. Secretary Kim Johnson,
Present.
Richard Cronick,
Present.
Ian Lewis, Elizabeth Mitchell,
Present.
Dr. Richard Pan,
Present.
Don Molds, 6 in attendance, 2 absent.
Thank you. We are going to, as discussed, we had a very productive lunch hour, so we're going to return to the meeting minutes, item 3A, and it looks like we actually have some language to share with the members.
My name is Jean-Paul Buchanan, I'm attorney for the board. Dr. Pan has provided me with the information he would like to see added to the minutes. This is on page 2, first bullet point under discussion and comments from board members. The language should read, a member commented on that Covered California kept the average premium increase around 1% for 2 years during the prior federal administration.
Thank you. And do we have acceptance of the amendment?
I move acceptance of the amendment.
And a second?
Second.
Perfect. Thank you. And we'll do a roll call vote.
Dr. David Carlisle.
Aye.
Sandra Hernandez. Secretary Kim Johnson.
Aye.
Richard Cronick.
Aye.
Ian Lewis. Elizabeth Mitchell.
Aye.
Dr. Richard Pan.
Aye.
4 ayes. Motion passes.
Thank you very much. We will return to our informational items. Item 4B is sector targets. I'll welcome Vishal and CJ for us on this item.
All right, good afternoon. My name is CJ Howard, and I'm joking already. I am the Assistant Deputy Director of the Healthcare Spending Targets branch within OCA. You can go to the next slide. So starting at the beginning here, we want to level set a little bit on the process for implementing sector targets. In essence, establishing sector targets is a 2-step process. First, the board needs to define sectors, which are then codified in regulation, and then the board can establish sector target values for the sectors. The process for establishing sector target values mirrors that of establishing the statewide target, wherein the office will propose target values on or before March 1. A 45-day public comment period would follow, and the board would then have until June 1 to approve the target values in the year prior to the performance year. So, for example, the board would need to approve target values for 2026, which would be the growth from 2025 to 2026, by June 1 of 2025. Today's discussion will focus predominantly on how to define a hospital sector, and the options presented later on in this presentation will address how to define and establish potential hospital sectors. The office can return in subsequent meetings, potentially as soon as January, with options on establishing the sector target values. Value or values. We could move on to the next slide. And one more slide. So in November, the board discussed potential attributes of facilities that may warrant special consideration when establishing a sector or sector target for disproportionately high-cost hospitals. The attributes discussed included critical access hospitals, small hospitals, psychiatric hospitals, children's hospitals, teaching and academic medical centers, specialty hospitals, state hospitals, county hospitals, and facilities that have long-term stay. Board members broadly suggested that many of these attributes may warrant distinction or consideration or even exclusion when defining a hospital sector and establishing sector targets for hospitals. Members suggested the following: factoring in geography or for rural areas to any hospital sector target. Since state and county hospitals rely minimally on commercial payment and in many cases are funded in whole or in part by state and local appropriations, they could warrant a lower spending target value. Or sorry, they may not warrant a lower spending target value. Psychiatric hospitals are funded differently by Medicare, so may warrant distinct considerations or treatment. Children's hospitals receive little Medicare funding, and some may have different billing practices. Long-term stay and specialty hospitals are likely a heterogeneous group, where some may warrant distinct treatment or consideration while others may not. Critical access hospitals and small hospitals, depending upon how they are defined, may not warrant lower targets. Most teaching hospitals and academic medical centers likely do not warrant distinct treatment. And the board also asked for a review of hospital data by facility attributes and several financial metrics, which follows in today's presentation and will be the bulk of today's presentation and discussion. If we can move to the next slide. So we'll now shift to the review of data that OCA conducted of California hospitals. So based on discussions with the board, the following data in this section shows the top 30 hospitals for each of 4 financial metrics from 2018 through 2022. I do want to emphasize, and we'll probably emphasize a couple times throughout the day, that these are select and illustrative set of metrics for the board's review and analysis. There are other metrics that could be used to assess and evaluate hospital price, spending, cost growth, and affordability. They are not meant to convey a methodology or a recommendation on how to define hospital sector or establish sector targets. We did identify measures, though, to address overall spending, spending growth, profitability, and indicators of price. So to evaluate spending at the hospital level, OCA sorted hospitals based on the average inpatient net patient revenue per case mix adjusted discharge. To evaluate spending growth at the hospital level, OCA sorted hospitals based on the average growth in inpatient MPR per CMAD. To evaluate profitability at the hospital, OCA sorted hospitals based on the average operating margin. And to evaluate relative price at the hospital level, OCA sorted hospitals based on the average payment to cost to third-party Medicare ratio. The first section shows the top 30 hospitals for each metric without any facility attributes excluded. And then the second section of the presentation shows the top 30 hospitals for each financial metric, as well as side-by-side comparison for how that facility ranks or the output of that facility on the other 3 financial metrics, with some hospital types excluded, again, merely for the sake of analysis and identifying and looking at a different set of hospitals in the hospital universe in California. The attributes that were excluded in the second set include critical access, psychiatric health facilities, state hospitals, long-term stay hospitals, small hospitals, children's hospitals, and Kaiser hospitals, as they are part of a fully integrated delivery system. So before we can go to the next slide, and before diving deeper into the data, I want to spend a little bit of time to clarify and define each of the data measures that are used in our review. So first is the hospital spending metric shared with the board at the November board meeting. This is inpatient net patient revenue per case mix adjusted discharge. As a reminder, it is the amount of money a hospital generates for inpatient services, excluding charity care, bad debt, and contractual allowances, adjusted by the number of hospitalizations to account for inpatient volume and inpatient intensity of services. Next is the growth metric. This is the annual growth in the inpatient MPR per CMAD. This refers to the year-over-year change expressed as a percentage in the amount of money a hospital generates per unit for inpatient services. Then there's a profitability metric, the operating margin, which refers to the net income from operations divided by total operating revenue, the net patient revenue plus other operating revenue. This ratio indicates the percentage of net patient revenue that remains as income after operating expenses have been deducted. A positive operating margin indicates profitability. Last is a price metric, the payment to cost third-party to Medicare ratio. It refers to the Medicare and third-party net patient revenue divided by Medicare and third-party costs. This ratio compares the amount a third-party payer pays for a medical service compared to what Medicare would pay for a comparable service, showing how much more or less the third party pays relative to Medicare's standard rate for that service. Again, to reiterate, this is not a definitive set of measures or metrics for assessing or analyzing facilities. There are potentially other metrics that could be used to also assess and evaluate hospital performance.
CJ, we just have one question.
Actually, a technical question, except presumably we'll probably take all questions at the end. how do you determine what's inpatient and outpatient? Is there a standard definition? Because I know there's sometimes some back and forth about that. So so for this definition, how are you defining inpatient service?
Gonna phone a friend to make sure that we say this right, but I know that.
So HCI gives the specifications to the hospitals on how to categorize it. It is an estimate, as Board Member Kronik mentioned earlier.
Okay. So is it an HCI definition, or do we use someone else's definition?
This is an HCI definition.
Okay, so HCI has its own definition of what's counted as inpatient versus, let's say, Medicare, some other organizations. Okay, then you don't have to go into details. I just want to understand that. Thank you.
All right, moving on to the next slide. We'll provide a walkthrough on the next two slides of the various facility attributes that our review makes mention of. So I'll also note that some of these definitions are firmly rooted in statute, while others were part of sort of analytical decision-making for the purposes of this review and analysis and discussion here today. So critical access hospitals represent a separate provider type with their own Medicare conditions of participation, as well as the separate payment method. The conditions of participation are listed in the Code of Federal Regulations. A small facility. For this analysis, OCA defines small hospitals as those with less than 100 licensed beds. A psychiatric hospital. The designation of a psychiatric hospital is self-reported in the HCI financial reporting. These hospitals provide a preponderance of psychiatric services. A psychiatric health facility is a small county-operated hospital licensed as a psychiatric health facility, providing mental health services to a unique patient mix. Children's hospitals. The designation of a children's hospital is also self-reported in HCI data. There are likely facilities that specialize in or focus on care for children that do not self-identify as a children's hospital. Teaching hospital. HCI identifies teaching hospitals based primarily on the American Medical Association's Graduate Medical Education Directory. Next slide. Specialty hospitals. There is not a statutory definition of what constitutes a specialty hospital. Examples of care provided in specialty hospitals may include rehabilitation, cancer treatment, heart surgery, addiction recovery, respiratory care, neurological services, long-term care, orthopedic surgery, and mental health care. We have designated public hospitals. Facilities defined as designated public hospitals. For this analysis, we pulled the definition from the Welfare and Institutions Code. There may be other county or predominantly county-run hospitals that are not included in this definition. State hospitals, hospitals that provide mental and behavioral health services to patients referred by a county court, a prison, or a parole board as defined in Welfare and Institutions Code. Long stay facility. For this analysis, OCA defines long stay facilities as those with an average length of stay greater than 20 days. And fully integrated delivery system hospitals, hospitals that are part of a fully integrated delivery system as defined in Health and Safety Code. As we can see, some of these facilities may merit consideration, but are not always readily or consistently defined in statute or regulation. Move to the next slide. All right, now that we've gotten the definitions out of the way, OCA would, again, just want to reiterate, this is not a proposal. This is merely for our analysis and to facilitate discussion. What we'll see in the slides to come is that it was difficult for OCA to intuit any clear or consistent trends or patterns in the data. So here is a summary of the select set of metrics OCA chose for the board's review and analysis, showing the range from high to low of the top ranking 30 hospitals statewide and the statewide median for each data measure, without any facilities excluded for the aforementioned attributes. So for the average inpatient NPR per CMAD, the top 30 hospitals range from $402,000 to $28,000, and the statewide median is $12,791. For the average annual growth in inpatient NPR per CMAD, the top 30 hospitals range from 79% to 15%, and the statewide median is 3%. The average operating margin, the top 30 range from 41% to 15%, and the statewide median is 1%. The average payment to cost to third party to Medicare ratio, the top 30 range from 857% to 300%, and the statewide median is 180%.
And can I just add a clarifying question? That's the average across all 4 years?
Correct.
Okay, thank you.
Yep, it's the average across all 4 years, and then we rank ordered them, and then you see the range of the top 30 and the median of all hospitals being ranked. So we can go to the next slide. So here OCA shows the top 15 hospitals ranked by average inpatient NPR per CMAD, again without any hospitals being excluded from the analysis, as we'll see from this slide. And from the slides that follow, there is a substantial amount of variation in hospitals for all 4 metrics. For this first metric, most hospitals have stays that are longer than 20 days, 13 of them. Slightly more than half, or 8, are small hospitals with less than 100 beds, 4 are critical access, 4 are psychiatric hospitals, and 2 are children's hospitals. And there is 1 teaching hospital and 1 specialty hospital in this group. Slightly more than half also fit into more than 1 category. Most are in metropolitan areas of Los Angeles and the Greater Bay Area. Go to the next slide. So this slide is the top 16 through 30 hospitals ranked by average inpatient CMAD without any of the facilities excluded. Again, the majority of hospitals here are with stays longer than 20 days, 11 of them. Slightly more than half are small hospitals with less than 100 beds, 4 are critical access, 3 specialty, 3 are public, and 2 are psychiatric, and 1 is indicated as a teaching hospital. 11 of them fit in more than 1 category. And at the county level, this group includes hospitals beyond LA, including Inyo, Plumas, Glenn, and Trinity counties, so more geographic dispersion in this group. So this next slide shares the top 15 hospitals for OCA's second metric, the average annual growth in inpatient NPR per CMAD. 10 are small hospitals, 9 are long-term stay hospitals, 4 are psychiatric hospitals, 3 are public, 2 are critical access, and 1 is a specialty hospital. 11 of them fit into more than 1 category. This is a diverse group county-wise, including counties in all regions of the state, from the Bay Area, Los Angeles, the Central Coast, the Central Valley, and the far northern part of the state. On the next slide, we show the 16 through 30 on the average annual growth in NPR per CMAD. 10 are small hospitals, 7 are long-term stay, 5 are psychiatric hospitals, 5 are critical access, 1 is a specialty, and 1 is a public hospital. And 10 would fit into more than 1 category. And again, this is diverse in terms of representing the state's geography. Go to the next slide. This is the top 15 on OCA's metric for the average operating margin. 9 are small hospitals, 9 are psychiatric hospitals, 4 are specialty hospitals, 2 are long-term stay hospitals, and 1 is a children's hospital, with 8 of them fitting into more than 1 category. Except for 1 hospital, this group includes hospitals clustered in Los Angeles and Southern California and the San Francisco and Bay Area regions. On the next slide, we show the 16 through 30 ranked on average operating margin. 4 are small hospitals, 3 are critical access hospitals, 2 are specialty hospitals, 2 are psychiatric hospitals, and 2 are long stay hospitals. And only 4 fit into more than 1 category. We can move on to the next slide. So this is the last metric that we reviewed. It's the average payment to cost third party to Medicare ratio. To recap, this metric looks at how Medicare covers costs, how commercial covers costs, and then takes a ratio of those two ratios. So if we look at the top hospital on the list, Monterey Park, we can interpret the 857% to mean that this hospital has a cost coverage of 8.5 times more than for commercial than it is for Medicare. So the reimbursement would be 8.5 times greater. Looking at variation, we see that five of the facilities are small hospitals. One is a critical access hospital, one is a children's hospital, one is a teaching hospital, and one is a long-term stay hospital. 2 of the 15 fit into more than one category, and county-wise, these are dispersed amongst the state's geography. And finally, here are the top 16 through 30 on this ratio. 4 are small, 2 are teaching hospitals, 1 is a specialty hospital, and 1 hospital out of this group fits into more than one category. In terms of geographic dispersion, 2 are from Los Angeles or Southern California. We see inclusion of more northern counties like Amador, Nevada, and Central Valley counties like Stanislaus and San Joaquin. We can move on to the next slide. Okay, so now we'll seek to narrow our scope and provide another review of the hospital metrics, but after excluding several facility types. We'll also be able to compare all 4 metrics side by side. Like the prior set of slides, OCA found that it was hard to intuit a clear and consistent trend in the data even after removing some facility types from the analysis. Potentially, for the last time today, I'll reiterate that this was not a proposal or a methodology for defining a sector or target values. So based on feedback from the board, OCA presents the following top 30 facilities, excluding hospitals with the following attributes: critical access hospitals, children's hospitals, psychiatric health facilities, small hospitals, and long-term stay hospitals. And here's a summary of how these facilities with the exclusions rank. For the average inpatient NPR for CMAD, the top 30 hospitals range from 54,000 to 18,000. The statewide median still 12,647. So it's the median of the restricted group. For average annual growth in inpatient NPR per CMAD, the top 30 hospitals range from 66% to 8%, and the statewide median is 3%. For average operating margin, the top 30 range from 39% to 12%. The statewide median is 2%. And for average payment to cost third party to Medicare ratio, the top 30 range from 857 to 276%, and the statewide median being 198%. So on the next slide, OCA shares the top 15 hospitals ranked by inpatient CMAD with the specified exclusions, followed by their outputs on the other 3 metrics. As we'll see from this slide and the slides that follow, there's a substantial amount of variation in hospitals for all metrics. For readability purpose, we want to note that if an output ranked in the top 15 for a metric, then it's shaded in dark blue. If an output ranked between 16 and 30 in a metric, then it is shaded a lighter blue. More than half of the hospitals that register in the top 15% in average NPR per CMAD are either public hospitals or those that can be designated as a teaching hospital or academic medical center. 11 of these hospitals reside in LA County or a Bay Area county. Of the hospitals appearing in the top 15 in average inpatient NPR per CMAD, 6 hospitals also appear in the top 30 in another metric. However, there's no discernible correlation. On the next slide, we show the top 16 through 30 hospitals on the inpatient NPR per CMAD metric. 5 hospitals that appear in the top 16 through 30 in average NPR per CMAD are those that can be designated as a teaching hospital or academic medical center. 12 of the hospitals reside in LA County or a Bay Area county. Of these hospitals appearing in the top 16 through 30, 9 hospitals also appear in the top 30 in another metric. I do want to note for Sacramento Behavioral Health Care, this facility did not report data for all 5 years. It was not included in the statewide calculation for operating margin. Can move to the next slide. So this slide shows the top 15 for OCA's second metric, the growth in inpatient NPR, with certain facilities pulled out of the analysis. 6 hospitals that appear in the top 15 in the average NPR, in the average growth, are public hospitals. 14 of these hospitals reside in Southern California. Of these hospitals appearing in the top 15, 7 hospitals also appear in the top 30 in another metric. On the next slide are the top 16 through 30 in average growth in NPR per CMAD. Of these hospitals appearing in the top 16 through 30 in average growth in inpatient NPR per CMAD, 7 hospitals reside in LA County, 5 appear in the top 30 of another metric. Moving on to the third metric of average operating margin. 6 hospitals that appear in the top 15 in the average operating margin are psychiatric hospitals. Of these hospitals appearing in the top 15, 6 hospitals also appear in the top 30 for another metric. On this next slide, for the top 16 through 30 for average operating margin, there is only 1 psychiatric hospital that appears in the top 16 through 30. Of these hospitals appearing in the top 16 through 30 for average operating margin, 6 hospitals also appear in the top 30 for another metric. And for the fourth metric that we discussed today, on the next slide, the average payment to cost third-party to Medicare ratio, there's only 1 academic medical center that appears in the top 15 for this metric. Of these hospitals appearing in the top 15 on this ratio, 7 hospitals also appear in the top 30 for another metric. And our final data focus slide today, focus on the top 16 through 30 for this ratio. There are 2 teaching hospitals that appear in the top 16 through 30. Of these hospitals appearing in the top 16 through 30 for average payment to cost to third-party ratio, 5 hospitals also appear in the top 30 for another metric. So having looked at the data, now we'll shift to a discussion about.
Yeah, let's open it up for questions. That's a lot of, first and foremost, thank you. That was a lot of data to kind of slice and dice in many different ways, but let's just stop here just for questions related to what was presented. Elizabeth?
Thank you. It was a lot of data. I just was curious, did you look at quality in any way, shape, or form, even like basic Medicare quality metrics, and is there any correlation? I know typically there is not, but.
For this analysis, we didn't.
There's no reason to believe that there are major quality differences or that they're at all related to price.
Yeah, we when Chris Whaley spoke to you all in August, he did kind of show that there's not a strong correlation.
Or really one, yeah.
Yeah.
Richard, please.
Appreciate the presentation. What's striking to me, and well, each of these are slightly different in terms of what they're measuring. You think about average inpatient NPR per CMAD, that in some senses reflects, how much, at least what they're bringing in, right? For, case adjusted, right? And then you have the average payment to third-party Medicare ratio. I guess the lack of correlation between the two is quite striking, actually. because while they don't measure identical things, you think they're kind of measuring sort of the same idea. So one's growth, what's different, growth than how much, and then obviously the operating margin could speak to the inefficiency of the facility given what they got, right? So a more efficient or cost-effective, hopefully would actually have theoretically a larger operating margin, although it could also be case mix, but we're doing case mix adjusting. But I guess to me, it is striking that the lack of correlation between these four measures, but particularly the Medicare party ratio and the average inpatient NPR, and trying to understand why those are not more related. Why is like you're okay in one but you're not in the other, and vice versa. Like you're actually there's even some that I was looking at this. There's number 5, Foothill Regional Medical Center. Is number 6. Is the 6th highest average inpatient NPR percent AD, but their average payment cost third-party Medicare ratio is only 82%. So they're actually below even 100%. Like, why is that the case? What's going on there? Would be interesting to know. Actually, the other thing I would note is I think the hospital in LA that is at 800% of Medicare, Monterey Park is not exactly a community where there aren't competitors. So why is it that they're at 800% and people are willing to pay them that? It's not like they're not, well, I would argue that they're probably, I don't think they're monopoly. I guess I have to look more closely, but it's certainly just knowing Monterey Park, that's not exactly an area where one hospital basically can put whatever price they want, yet they are at the very top. And so why is it? So the whys, I guess, to me, are going to be important to understand. How do we put together the right thing for the sector target? Otherwise, we're going to have some unintended consequences we're going to create. So that's just an observation given the data you presented.
We wanted to check with Board Member Kronik if you wanted to kind of explain, because we did use your study to calculate the cost, payment to cost ratios, and how that may or may not correlate with the average inpatient NPR.
I have only a partial answer for you, Richard, but the partial answer is that Medicare payment recognizes differences across hospitals in input costs. So hospitals in higher wage areas of the state have higher Medicare payment. Recognizes that teaching hospitals have higher costs, and so payment is higher per case mix adjusted discharge. Medicare payment is higher. And so you wouldn't expect a particularly strong correlation between the two measures, although there should be some relationship. And looking at these data, it's a little hard to tell from how it's presented, but I think there is some relationship. I do think that the Medicare, the average payment to cost third party to Medicare ratio, which is a kind of a difficult phrase, is probably a better measure of the extent to which hospitals are extracting high prices from private payers. It takes, and we had to, I mentioned this, I think, at the last meeting, sort of, it makes the assumption that Medicare payment is reasonable. And certainly many hospitals would argue with that, but that, it makes the assumption that the Medicare methodology is a sort of good starting place, and that looking at the ratio of what private insurers are paying to what Medicare is paying is a good way of assessing the pricing behavior on the private side. And to your kind of question, there'll be some hospitals that have high ratios of third party to Medicare payment, but not particularly high costs. And those are hospitals where, that are not teaching hospitals in areas of the state without high wage indices for the most part, I would think.
If I may just, so first of all, I guess on the teaching hospital side, is the indirect medical education payment folded because that's an adjustment on the payment? Is that in your formulation? Is that incorporated into the reimbursement rate for the DRGs?
Assuming that the hospitals reported in the annual financial disclosure data their full payments for Medicare, which is I think what they're instructed to do. If they're reporting correctly, it should be in there.
Then that should be in there. Okay, so the IMG, the indirect medical education cost, or IMEA, is folded into there. And then the other question I have for you, again, I appreciate the explanation, is that one of the struggles we've had is I mentioned earlier the GYPSY, which actually, well, let's say so basically when Medicare was established, we established different geographic areas, right? Sacramento, which is quite urban, was classified as rural, essentially like geographic area 99, which is rural. So it doesn't really reflect, and that's happened in many parts of the state because they've grown since Medicare was first established, when they established these geographic adjustments at the time. So is that could have an impact, because basically your baseline is much lower, even though your costs are higher, because you're actually operating your facility in a more expensive, in an urbanized area, where costs are higher. Is how much of a factor might that be in terms of when you look at the ratios to Medicare payment?
So when you're referring to GYPSY, and we're getting deep into weeds here, that's a metric used in physician payment.
Yeah, it is.
Just physician payments. Hospital payments are adjusted differently by CMS using a wage index at the county level.
Okay, it's by county. Yeah. Okay, so your baseline could be adjusted, but of course counties, have a mix of, depending on how big the county is. All right. Okay, that's helpful. Thank you.
Thank you. I thought this was, of course, fascinating. As somebody who's, when I was doing my dissertation, was doing a lot of secondary data analysis, especially on some hospital characteristics. And the first thing that struck me was exactly what Dr. Pan pointed out, the apparent absence of correlation between the measures. And then I thought, but we're only looking at less than 10% of the environment here. And I wanted to ask the team, if you actually looked across these measures, did some correlate more strongly with others than is apparent here? That's one question. The other thing that occurred to me, and it's always difficult to draw generalizations from a subset like this, but I'm noticing an absence of Los Angeles area facilities. My recollection is LA at least used to have as much as maybe 20%, 25% of California hospitals. And given that, on these top outliers, they seem to be relatively underrepresented here. And we see facilities maybe that are more found in small counties. I don't want to overgeneralize, but I would say that clearly there seems to be a geographic factor here that may be important. But I want to ask the correlation question using the entire spectrum of facilities.
Yeah, we could, as far as the two measures that we just spoke about, average inpatient NPR per CMAT, and then the payment ratio, which internally we called the chronic ratio for shorthand. They're measuring different things. The average inpatient NPR is measuring kind of all payers versus the ratio is kind of taking into account expense. I'll turn it over to our colleagues, Sarah Lindberg at Friedman Healthcare, to kind of walk you through why they're not correlated.
Hi, Sarah Lindberg, Friedman Healthcare. Yeah, so average inpatient NPR per CMAD, that's just a purely revenue-based measure, and it's going to be all payers combined together. So it's not directly accounting for any of the payer mix. Whereas our ratio there is looking at how much cost coverage there is in a private plan versus how much cost coverage there is for Medicare. And so that's really looking at payer-specific payment characteristics. So they're measuring different things is kind of the long and short of it. We did run from that same paper the cost per adjusted admission, and that was very highly correlated with the average inpatient NPR per CMAD, with the chronic measure being higher just because it includes all revenue and not just the inpatient side. So slightly different things. One is really a ratio of how much payments are accounting for costs, which are assumed to be equally borne across payers. One is purely just revenue for all patients on a per unit basis. I hope that helps a little bit.
If I can jump in, since my name's been used first, I would suggest calling it the Whaley measure if we need shorthand. And I thank you for the presentation, which is helpful, if a bit overwhelming. And I think I mentioned this at the last meeting. I do think it would be helpful to look at least the average payment to cost ratio measure at a geographic level, and maybe in the absence of having defined hospital markets, maybe at a county level would be the easiest and best place to, or a good place to start. I'm looking at slides 62 and 63, and do see, the third highest hospital on slide 62 is a Monterey hospital, as is the 8th highest hospital. Can imagine that Monterey County, which as we all know is part of the motivation here, may look different than other counties in the state. Because I kind of part of the question that will face us is we're trying to figure out, are there some hospitals that should have different targets than other hospitals? Part of that question is not, I think, just about individual facilities, but about the markets in which they're operating. And so looking at this ideally at a market level, but in the absence of market definitions at a county level, I think would be very helpful.
We can certainly take that back and see what we can do with the data.
Thank you. I have a couple things which I hope are relevant. But first, I wanted to add an embellishment to Rick's explanation of reimbursements being set at the county level. I confess to having been a hospital lobbyist who was assigned to increase the wage index for our rural hospital by attaching ourselves to another area. So just, again, I think I'm doing penance right now, but there's a lot of politics in increasing those reimbursements, that in addition to the straightforward data. One thing is it possible to sort these by rural versus urban? I mean, I know we could just sort of do that, but I think there is a big concern around rural access. And has that filter been applied here, or could it be?
Fine.
I mean, I think one of the proxies for this urban-rural divide could be critical access hospitals.
No, because they have a different reimbursement mechanism, right? Just sort of trying to understand the access issues that people are appropriately concerned about.
Yeah, I think it's an excellent flag. Absolutely, we're concerned about the rural hospitals, and we've stood up the distressed hospital loan program. And so we will absolutely take back trying to evaluate how to look at that piece most effectively.
Okay. Elizabeth, is a suggestion to kind of look beyond critical access hospitals?
Yes.
Okay.
Because there's several rural hospitals that aren't critical access, correct? Okay. Yeah. And then one other potential question. Is there any universe where like the top 5 here that show -1%, -2% average growth, even though they're at like 800% of Medicare, would somehow be under the 3% cap? Like, is there any math that would make that possible? Because that would be a problem.
Zero.
Like, because if they're at a negative growth rate, but they're already at 857%, I don't think we're achieving our aims.
So is the question kind of how do we get if a target was placed that was below 3%, or I'll let you kind of restate your question, just so I'm following.
I'm not quite sure how, but my question is there a scenario where we, credit hospitals with having met coming in below the 3% because they're already at 850?
Yes, I mean, today, absolutely. They're subject to 3.5 in 2025 and 2026, and we're starting with where they're starting from. Yes.
Seems ironic.
I guess, I mean, the anxiety is that, we have hospitals conceivably here that are losing money. Maybe, I mean, for all sorts of different possible reasons, including the fact that they're, potentially in very competitive areas and needing to do that to stay competitive. And then you have, at the other extreme, you have hospitals that are the only hospitals in town or one of a couple that are at multiples, sometimes double the statewide average, sometimes more than 4 times the statewide average, and them rolling in at a 5% increase is very different than these hospitals that are in already putting out very competitive prices. And that if we're going to hit our statewide targets, there's going to need to be some level of enforcement across the board. But I think what I heard you saying, and I'll say it for myself, I think we feel better about some of these than others. There are understandable scenarios, and I know that these are folks who come in for a conversation with you, and that you have pretty broad ability to negotiate with them or apply and not apply and so forth, and there'll be some of that, but the statewide target is predicated on the assumption that everybody is hitting the number.
Well, even just looking at this chart, and again, realizing this is just the top 30, so the question is how much it reflects the pattern. But as I point out, Monterey Park hospitals in Los Angeles, I guess their operating margins 12%, so at the higher end. Their inpatient NPR per CMAD, which is of course revenue, interesting enough, is at the lower end, maybe at the more toward, I forgot what the average is for that. So maybe
it's
more.
I think it's just below the statewide median.
Yeah, so basically they're at around the statewide median. So, but their average payment per cost for Medicare is 857%. I'm trying to figure out, like, okay, so aside from the loss that they're down 1%, how does that all come together? Is it because the wage structure, and they're in Los Angeles, so how do they come at 887 at the average NPR, which I agree is just revenue, but they're in Los Angeles, so you think the wage structure would be higher? So I'm just trying to figure out how these all things come together, right? So I get it that it's the average NPR is a revenue thing, and the Medicare ratio includes but is it what is it about their cost structure that is making them, and they're in Los Angeles, right? And then I think about this, I look at the second one, Barton Memorial Hospital in El Dorado, 799, right? So obviously their inpatient CMAD's a bit above average. Their operating ratio is lower at 6%. Not it's not running negative, but and then El Dorado is a bit more rural, right, out there. I'm trying to figure out exactly where it was in the county.
If I can
So,
jump in,
yeah.
Richard. I mean, those two hospitals are such outliers on this metric.
Yeah.
Further investigation needed. Is likely that is bad data. Is my.
Yeah. So I guess I just want.
At least possible. Likely might be too strong. At least possible.
Right.
Maybe the reporting.
Yeah. Something's not right. Something doesn't make sense here. And again, bad data is always as I said, when you get a test that doesn't make sense, the first thing we do is repeat it, because we're not that they mix up the tubes. It's something else, because it just doesn't make sense. So.
Yeah, Dr. Pan, we could have Sarah Lindberg elaborate on kind of these outlier cases. Typically, the ratio we see, it wouldn't be surprising to see like a 300 or 400% of a ratio, but in the case of these outliers, it really kind of depends on what's going on in the numerator and denominator. So I'll let Sarah kind of elaborate on that.
Okay.
Sure, thanks. Sarah Lindberg here again from Friedman Healthcare. So it's important to remember that, this does have a numerator and a denominator. So it's possible that either the cost coverage is really significant for the other third-party payments, or it could be that the cost coverage is really poor for Medicare. Either way, these outlier cases likely do have something funky going on, whether that be poor, incorrect reporting, or just kind of an anomaly in a year or two. Since these are averages over time, one really funky year could throw this off. So I agree that further investigation is warranted, and I think that any of these measures are going to have those situations where you'll kind of have some things that don't quite add up. I don't have those at my fingertips, but certainly can follow up with the story behind those two.
One other comment following up on Don's earlier comment about the 3.5% statewide average. I think it would be very helpful to see data on trends in the number of inpatient admissions per California, because Don mentioned the 3.5% average and sort of hospitals above and below, and sort of how do we hit that? If we're going to be looking at growth in inpatient net patient revenue per CMAD, the relationship of that to the 3.5% depends a lot on what's happening to admissions. If the number of admissions are going up, then even if inpatient revenue per CMAD were at 3.5%, total spending will be much more than 3.5%. And if conversely the number of admissions are going down, then we could hit 3.5% even if revenue per CMAD were at 4 or 5 or 6%. So I think as we're trying to think about the relationship of what we're looking at in hospitals to the statewide target, information on volume is very important to have. And I know on the outpatient side, which is probably even more important, we're not there. We probably, other than measuring visits, we don't have a good measure of outpatient volume, and visits is not a very good measure. But at least on the inpatient side, we ought to be able to have some data both on number of admissions and on case mix changes, although the case mix changes have coding problems with them. I would be hopeful that before we get to too far down this road, that we could have some volume information.
Yeah, we expect to kind of follow up on data issues in the coming meetings.
So appreciate all of those reflections on the data. I think you have some additional considerations now, given what you have here for us to discuss.
Yep, and so I think as we pointed out and as this conversation reinforced, we didn't intuit any really clear correlations or rules by which we might think of a particular subset of hospitals. And so we'll get into sector definition and target setting options. We can advance the slides. I think it's 2 slides from where we currently are. So we'll get into defining hospital sectors. So in response to board requests, the office has identified options for the board's consideration to address disproportionately high-cost hospitals. In November, the board expressed interest in potentially defining other sectors based on geographic region, medical group, or provider organizations and market category. Based on timing and data availability, the office has limited the scope of today's discussion to defining a potential hospital sector. Statute requires the board to define initial sectors on or before October 1st, 2027, and that the setting of different targets by healthcare sector is informed by historical cost and other relevant supplemental data. To define a sector and establish targets for performance year 2026, the board would need to establish a sector definition, and the office would need to recommend target values on or before March 1st of 2025. The office has limited data to inform the establishment of the potential sectors beyond hospitals. With regard to physician organizations, the office has very limited data on total medical expense growth attributed to physician organizations. The office is developing strategies to improve physician organization reporting. In terms of geographic regions, the office has limited data on regional total medical expenditure growth to inform defining appropriate geographic regions. Additional annual data reporting and supplemental data sets will be informative to defining geographic sectors in future years. And in terms of the markets categories, additional data reporting and analysis of California's cost growth trends may inform defining market categories and target values.
Since we're going to focus on hospital targets at this, so in terms of geographic regions, we talked about the covered California ones. There isn't data from covered California, other sources on, because health plans have been bidding on that for, I guess at this point, over a decade.
We do have some. I think there may be some other data that we would be able to pull from. I just don't think that it's comprehensive at this point that we were ready to get into that discussion.
Yeah, certainly Covered California has data based on their regions, as you know, Dr. Pan, but we can't set statewide targets based on that necessarily. So we've gotten the THCE data for 2022, 2023. We'll be doing our first baseline report, as you know, this spring, and we hopefully, CJ, are going to include some geographic analysis at that point.
Just really quickly on this. I know you don't have the data, we can't do it, but as for bulleting things we can't do, I would very much like to see health systems on this list of things that we can't yet do, but that are important to be working towards.
Duly noted.
I agree with that, including health systems. And maybe this is just for like another day, but I assume we will be talking about health plans, PBMs, pharma. There's a lot of other cost drivers beyond hospitals and health systems. Will we be looking at those?
Yeah, I think it's a great point that certainly there could be a target specifically on health plan. There could be a sector target for health plans. PBMs and pharma are a different issue because of current licensure and because of federal precedent issues. But certainly we could set one on health plans. So this is sort of a non-exclusive, a non-exhaustive list.
Okay, thank you.
So since we're going to talk about hospitals but not health plans, do we have a sense, because it's interesting that it's not even listed in this, like we can't do this, but so do we have a timeline for when we'd be looking at health plans as also a sector target?
We're focusing on hospital target, in response to stakeholder concerns raised and board interest in it. And certainly with the THCE data that we've now collected from health plans and the baseline report, it's something we could look at next year.
Okay, well, I'll put a pin on that.
Yeah, I'll join him in that. I think that's quite urgent.
All right. We move on to the next slide. So based on discussions with the board, the office has developed options to enable the board to establish sector targets to address high-cost hospitals as soon as 2026 performance year. These options focus on how to define and establish sectors, and the office can return in subsequent meetings with options on establishing actual sector target values or values. So the one option is to wait to establish sector targets for performance year until performance year 2027 or later. Another option is to define Community Hospital of the Monterey Peninsula, Salinas Valley Memorial Hospital, and Natividad Medical Center as a sector and establish targets for those facilities. Establish a sector based on facility attributes and financial measures, and define all hospitals as a sector and adjust the sector target value for select facilities. So if we move to the next slide.
And, are we waiting to the end for comment? And that's fine.
I think we'll maybe get through these options, and unless it's a technical question related to it, and then we'll open it up.
Great. I'll try to run through the 4 options fairly quickly. Post haste. So one option is that the board could wait to establish sector targets for performance year until performance year 2027 or later. For statute, the board shall define initial sectors by October of 2027 and establish sector targets in 2028, which would be for performance year 2029. Nothing precludes the board, though, from defining sectors and sector targets ahead of this time frame. Were the board to wait to establish sector targets until performance year 2027, the office would return by March 1 of 2026 with proposed target values and would work with the board to define sectors prior to March 1 of 2026. Next slide. Some things to evaluate or to consider when evaluating this option include that all facilities are still subject to the statewide spending target until a specified target value is established. For many facilities, the statewide spending target will be a reduction in spending growth compared with historical trends. Waiting to develop a hospital sector target allows the office to direct attention to other efforts, such as physician organization attribution and spending target enforcement. To implement this option, the office and the board will continue to analyze data and evaluate approaches to implementing sector targets, including high-cost hospitals. If we move to the next slide, another option is the board could define the 3 Monterey facilities as a sector and establish targets for them. I want to point out that per statute, the definition of the sector shall be promulgated in regulations, and that once established, the board may adjust a healthcare entity's sector target in comparison to other healthcare entities in the sector or geographic region. Next slide. Some things to consider when evaluating this option include this approach is narrowly tailored to address 3 hospitals that have been brought to the board's attention. Defining such a narrow sector would limit the board's ability to later adjust spending target to only these facilities until further facilities or sectors were defined. The board would still be able to adjust the target value for these 3 facilities in relation to each one's baseline costs. And various stakeholders would likely challenge why these 3 facilities are defined as a single sector when the data do show that there are other high-cost hospitals. To implement this option, the board would vote to define the 3 hospitals as a sector at a future board meeting. The office would draft and seek to implement regulations defining the sector, and the office would return to the board with options for establishing target value or values for the sector. A third option is the board could define a high-cost hospital sector that includes a subset of hospitals based on facilities that are disproportionately high cost. Define potential inclusion and or exclusion criteria based on financial metrics and facility attributes, and establish targets for those facilities. Some things to consider when evaluating this option on the next slide include the board would need to decide which metrics should be used to determine which facilities would be included or excluded in the sector. Not all attributes that may warrant inclusion or exclusion are readily identifiable or defined in statute or regulation, and many are an artifact of self-reporting. The board may need to develop definitions for these facility attributes and potentially how financial measures would be operationalized in the definition. This approach may unintentionally include or exclude entities that may warrant a target different from the statewide target. This approach would require additional time to develop and implement, and the office would not be able to implement sector definition regulations and recommend target values for performance year 2026. To implement this option, the office would continue to work with the board on developing a process based on financial measures and facility attributes for defining hospitals that would be included in the sector definition. And once the process for defining included hospitals is agreed upon, the office would seek to promulgate regulations and return to the board with options for establishing target values for the sector. In the fourth option and last option that we've developed, the board could define all hospitals as a sector. If established as a sector, hospitals would be subject to the statewide target unless and until the board adjusts the target for all or a specific subset of hospitals within the sector. Some things to consider when evaluating this option include that this allows the board to consider the unique attributes of each facility and adjust cost targets of individual hospitals to account for baseline costs in comparison to other hospitals in the sector and geographic region. It enables the board to strategically modify, tailor, and adapt its use of sector target tool to promote consumer affordability. This approach would not limit the board from adding additional sectors in the future, such as geographic sectors. Enables the board to adjust targets for all or a select portion of the hospitals in the sector. The approach for measuring and reporting hospital performance against the spending target will be different from health plans and other provider types that rely upon attributed TME growth. Establishing hospitals as their own sector aligns with the artifact that they are measured differently. This option could be implemented to enable adjusting of sector targets as soon as performance year 2026. So to implement this option, in January, the office would present the sector definition options to the advisory committee for their feedback. The board would vote to define hospitals as a sector. In February, the office would draft regulations with the approved sector definition, present it to the board, and seek OAL approval. The office would make a recommendation for sector target values and present it to the board. From February to April of 2025, the board would discuss appropriate hospitals to adjust the sector target for, so we would continue sector target development. The office would present the proposed target values to the advisory committee for their feedback. There would be a 45-day public comment period that would begin the day of the February board meeting if the office presents recommended target values, and then the board would be able to vote on sector target values and make any adjustments for the selected hospitals on or before June 1. And this last slide is just a timeline of how option 4 could be implemented, showing the sort of different two steps in the process and how there's some overlap in setting the sector targets as well as defining the sector. And then last slide is the office's recommendation to the board, which is if the board intends to proceed with sector targets effective for calendar year or performance year 2026, then OCA recommends implementing option 4. Option 4 will provide the board with the ability to consider the details and attributes of each hospital prior to implementing its target value that differs from the statewide spending target. This option enables the board to respond timely to facilities with spending trends that do not advance consumer affordability.
Don, did you want to jump in?
You can go ahead.
Thank you. Just a clarification. These recommendations aren't necessarily mutually exclusive, right? Other than option 1, which I would not support. But like we could theoretically, approve option 2 today, theoretically, and then also do option 4. So for 2026, we have a more refined set of industry targets. Is that correct?
We haven't noticed an action item today, so the board can't vote. But
Yeah,
you
sorry,
just
that wasn't really the point.
indicating your inclination.
No, I was just saying. I was asking. I guess they're not mutually exclusive. We could choose more than one, or other than option 1, which
So
really is.
if the board decides to define hospitals as a sector, then you'd have the flexibility to pick which hospital, to identify which hospitals. I guess, option 4 is structured a little bit differently because it's using metrics as opposed to the 3 hospitals as they are.
Option three would be a little bit different in terms of using metrics, but I think your question is, could the board theoretically in January establish a sector of the 3 Monterey facilities, that's a sector, and all hospitals as a sector? Could you do both
Correct.
of them?
That's my question.
I would tentatively want to say I believe that that could be workable, but would want to think through that carefully.
Could we also, so just a potential variant on option four, could we say, and let me make sure I understand option 4 before I go down that path, but option 4 is essentially giving you all the discretion to be more aggressive or less aggressive with respect to the 3.5% and the 3%, depending on attributes of particular hospitals. So it would allow you to go in and say, for a hospital that's at 650% of Medicare, you're at 0. Is that a fair interpretation of option 4? Or conceivably the other direction. So if we had one of these hospitals that is at 120% of Medicare and it's been operating with negative margins for 5 years and is looking for 5, there might be some flexibility there. Is that?
Yeah, I would correct that it's not OCA. It would be the board defining the sector, and then the board would also be, it would be a board decision on which hospital facilities to adjust the target for.
So we would be essentially, well, so you guys have flexibility in your process to be permissive if you have someone who comes in, if you have a hospital that comes in that has a compelling story, you have the ability to say, okay, we're going to let you go this year at 4%, but we want to see this kind of plan going forward so that you get under the spending target. You have that flexibility in your own application of the spending growth targets, right?
On the back end, for entities that exceed the target that this board has set, we will do an analysis as to whether it's justified, and we'll be talking to you about that enforcement approach.
Yeah.
But you know, only the board can set the targets. So if the board chooses option 4 and hospitals are set, then we will come back with a recommendation about which hospitals and with your input.
So if we wanted to, but so that's for the ones that miss the target. For the ones that we might want to see come in below the target, that's a board action.
Correct.
Got it. Okay, that makes sense. Now, and if we were to lay out, as opposed to particular hospitals, criteria, would that be an option too? So
yeah.
You know, more than double the statewide average as a percent of Medicare, and you know, doesn't have any really good reason to do it for being where they are. I mean, it would be much more sophisticated than that, but we could do something like that.
Yes. So if the board were to go with option 4 and say hospitals are a sector, so that gets put in the regulations, and then the board has the authority to say we want to go, you know, we want to target hospitals that are whatever percent of Medicare or above.
Okay, but at that point, then it would be. The board would have to make those individual decisions about which hospitals fell in, or
only the board can adopt a spending target.
Okay, but if the spending target were attributes if the spending target were going to be lower and attributes of hospitals that should have a lower spending target, I would think that would be the action to adopt. And that you guys then would figure out who falls into that category.
Correct.
Okay, yeah, I just want to make sure. Okay,
we would make a recommendation.
Yeah.
For you to react to.
Yeah.
Okay.
Based on your input today and ongoing.
Huh.
And the board, as you did last time, would adjust and vote.
Okay. I mean, I think that's Anyway, okay.
And I have to admit, I'm not an attorney, but I helped draft the legislation. So I think the idea is that we, of course, have the power to set the targets. We can set parameters and say, if you meet these parameters, this is what your target will be. I don't think we have to necessarily list on the specific list of facilities. I think we can say the target, if you are a hospital licensed, blah, 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 right, and et cetera. And you probably can't just say no good reason, but like, and you don't have these reasons, et cetera, then this is the target that you'll be held to. The staff would apply that and say you fit into that category, therefore that's the cost target you meet. And if you don't meet that, staff does have flexibility in terms of enforcement, improvement plans, et cetera. Although you do have to notify us if it turns out you're going to fine them or something, I believe, if I remember correctly. So there's a little bit on the like what happens if you don't. So it's not that we have to have a target for here's the specific list of facilities. Of course, I assume we might ask the staff, hey, if we do this parameter, which facilities might fall in there, but our vote, or I think what we'd approve, and of course council can correct me if I'm wrong, but I recall correctly, is that we would say the target would be X% for people, facilities that fall under X, Y, and Z. I guess from what you're saying, and I think if I heard you correctly, I would be more inclined to have the board decide those parameters and set targets for things than trying to name specific facilities. I think that's a little trickier because it does look like, people and again, I'm not a lawyer.
I agree with that completely.
Yeah.
I mean, that's why I was asking all these questions, because that's where I was hoping we would be able to go, because that's a much more rational approach. And
right,
I'll also add, as the person without a vote, that seems like the way to go. And part of the reason is the concern that Elizabeth raised, that I sort of jumped on the bandwagon of, and that is that we have such variation that we have to use all of the tools at our disposal to. I mean, it's an irrational variation. There will be some variation is rational. What we're looking at is crazy, and we need to put it into a range that more accurately reflects actual costs than these range of prices that could not possibly flow from actual costs.
As a potential enhancement, I don't know if this is appropriate or doable, but a couple of our members are now requiring justifications for charges over 250% of Medicare. Like, just they won't pay it until they get a rationale. I mean, is there anything like qualitative we can require? Like, why are you at 850% Medicare? Or just some way to get at Don's, observation about how crazy these variations are. I mean, I think we know, but
for entities that exceed the target, one of our, we have we have a progressive enforcement approach. One of which is to sit down and understand from the entity why the prices are high. So we could ask at that point, and for an individualized. We don't have authority, to have some generalized reporting of that.
But I think we did say there would be some coming back to the board related to some of the outliers, just to make sure there's a data quality issue. So to the extent that there are significant outliers, we are at least inquiring to better understand, is it a data quality issue? Right, okay. Rick?
Thanks. Along the lines of trying to understand division of responsibility between the board and the office, the board's responsibility to set targets and to agree on algorithms or vote on algorithms of what kinds of hospitals might potentially have different targets, as we've discussed. Whose responsibility is it to define what it is that would be measured to know whether a hospital has met this target or not?
That would be OCA's responsibility, just similar to TME or total healthcare expenditures on the plan and physician organization side. So we made a lot of progress, at the last meeting explaining the inpatient side, and then the director talked about some of the gaps on the outpatient side. So that's going to continue on into 2025. But with the sector targets, there is kind of a timeline. But we do think that the measurement piece can happen in parallel.
And so if we were to vote on sector targets in the June meeting and potentially on the characteristics of facilities that might have their separate, that might have different targets than the overall target for the hospital sector, would we know at that meeting what was going to be measured, or is that something that would come later?
We're still working on that. As the director mentioned, we would come back in a couple months to give an update on the outpatient piece. But similar to the way when the statewide spending target was adopted, we did not, that happened in April of 2024. In January of that year, we did say we're going to start the hospital measurement work. So those could happen in parallel. It doesn't necessarily need to be, we have to figure out the measurement piece before a target is adopted.
Mm-hmm. Yeah, I would think certainly that for hospitals that are, and this is true even with the statewide target, but would be even more true for, or more salient for hospitals that might potentially have targets below the statewide target, that if we say to an institution, something can't increase by more than 1% next year, that it would be fair for the institution to say, okay, tell me what that something is, please. Yeah.
Thank you. Yeah, well, let's put it this way. Certainly the staff is the one who has the technical expertise but I would argue that our authority to set the targets also therefore means we have authority to specify how things are measured. Now, obviously, we don't want to make stuff up, so we need to work closely with the staff on that to be sure that we don't just pick a number. That how it goes into what defines that number is going to be important. So having some idea, having recognized that it may not have all the details in place, but at least we need to have a clear concept of how things are going to be applied to achieve the number that we've decided on that is going to be enforced. So I think it's a little bit back and forth. It's not purely just like, oh, staff decides. I mean, we have a role in that, and because that's how we determine the number. The other thing I guess I would also is just more broadly in terms of the hospital sector. One of the factors I think we need to try to, we talked about how some of the challenges of trying to measure outpatient, right? And we know it's not just inpatient, and we saw a bunch of numbers about inpatient. And the mix between inpatient and outpatient for hospitals, I mean, that all comes together, right? So if we're only looking at, so when we see hospital sector, I think we're not just saying we're only looking at inpatient as defined by HCI, right? We're actually looking at, and because it's, money does flow back and forth too. And I don't want to have unintended consequences. So I think when we think about the hospital sector, hopefully we're really talking about not just inpatient, but hospitals, and also sometimes they may own or have very close relationships with outpatient. So as we're trying to define this hospital sector, I just want to be sure that it's actually and we talked about health systems, sort of an appropriate unit, right? That and that we're not driven solely by, well, this is easy to measure, so therefore we're going to, because I'm afraid that if we're only looking at one piece of it, that we may have unintended consequences, actually even on affordability, because if the inpatient is helping support the outpatient, now we're saying camp down the inpatient, but we're not even looking at what the impact is on the outpatient side of things. And it could be the other way around, in which case we're not going to touch it either, and we need to know. So I realize we discussed some struggles with that, right? We didn't like the just attribute to it because that's not accurate, but hopefully as we're talking about hospital sector, we are talking about sort of the hospital or any associated health system that it may be at the center of, and not just the inpatient part of the hospital.
Yeah, I would say that the measurement approach would not just be limited to inpatient, it would be outpatient. And one of the measures we did present, the payment to cost ratio, it's inclusive of both inpatient and outpatient services, both the payment side and the expense part of that calculation. So we would return with a measurement approach that just so it's not squarely limited to inpatient growth. Yeah.
Yes, I just wanted to also express a lot of alignment with option 4. I think it's a nice starting point. Additional complexities are there that we'll have to consider subsequently. I think for me, one of the highest priorities is the geographic possibility of the sector. Options 2 and 3, I think, speak to that. I think it's important, but I'm not sure that we're ready to at least from my perspective, to make that conclusion at that time. So my priority is actually option 4 at this point with hospitals as a global sector. I think it'll capture a lot of what we're interested in already in terms of option 2 and 3.
Highlight the dates there again that were outlined as part of the options, and maybe if we can put the slide on for option 4 that actually specified some of that might be helpful. But I think as the office is going back based on this conversation on some of the data questions and additions that the board made, just again making sure that there's not other things that the board needs to be able to bring up any of the options going forward. Go ahead.
So just to clarify, because 3 and 4 seem kind of overlapping or similar, especially given the discussion we had about what 4 might be, because 3 was established sector based on facility attributes and financial measures, but also we've talked about a hospital sector that we would have potentially within that sector different cost targets based on facility attributes and financial measures. So I just want to clarify the difference between 3 and 4, or are they different, and exactly what 4 is compared to 3?
3 is kind of more defining a high-cost hospital sector. And then as we showed in the data slides, there's not a way we could just kind of say, 90th percentile, kind of anyone above that, they're a high-cost hospital because of the complexity we showed you. Some of them are long-stay hospitals, and we don't want to necessarily pick up entities that may not be the focus. Or that was just an example. There's other, types of facilities. Versus option 4 is, on its face, hospitals are a sector of the healthcare industry, and OCA is going to measure them in a different way. We're not collecting data from them in the same way we are with payers. So they are different options. Yeah.
Okay, but what could result? I'm sorry, I just wanted to clarify. So, is that what could result is, well, while sector 3, we may say, okay, there's a certain definition of high-cost hospitals, and we're going to set, let's say, a cost target that's lower than the 3.5 that we've decided for the overall. We could have an option 4 where literally there is a subset that is a high-cost hospitals where we set a lower sector, and the rest of the hospitals may say, well, we'll just keep you at 3.5 with everyone else.
That's right.
So so the outcome may actually be somewhat similar, but all right, just want to clarify that. Thank you.
The distinction with option 3 is that if it would take us longer to develop a rules-based approach.
But when we roll back into this conversation, you're going to be making recommendations about possible rules-based approaches. Okay.
Yes.
On the target setting.
On the target,
as opposed to how the sector is defined.
Yeah.
Appreciate that conversation very much, and I imagine there are others who would like to weigh in, so we will open it up for public comment on this informational item.
We'll now move to public comment on this item. If you're in the room, step to the podium. If you're online, please raise your hand. If you're dialing in, please press *5. Please limit your comments to this agenda item. We will have a general public comment period at the end of the meeting, and please try to keep your comments to 2 minutes. To the podium.
Members of the board, staff, public at large, Steve McDougall, representing CFT in this space, but also one of my other hats is I'm president of the JPA known as MICSIG, Municipalities, Colleges, and Schools Insurance Group, based in Salinas, California, and Monterey County. We had to have a special meeting of our full board last week. And I don't know if you were able to get the news wire from Monterey County. I did share something on email overnight from one of our local TV affiliates. MCSIG had to have a meeting of our 30 participating school districts and a couple public government entities. Our October claims came in, and November as well, which are not finalized yet. But the debt to our fund doubled in about a 4 to 8 week period this fall. So we had to have a meeting to basically send an invoice to every school district and government entity that participates in MCSIG to pay that debt that we incurred almost immediately, certainly by January, or work out a payment plan by June 30th if they can't swing it all in one fell swoop. Almost $7 million, most of which was in Monterey County provider facilities. And the oncology is amazing. The chemotherapy drugs are being paid out at a reimbursement rate that it's 6, 7, 8 times what Medicare would do. These school districts, most of which are school districts, they're going to have to figure out how to take that, make that work in their budget through negotiations with the employee groups, meaning no raises, more costs for health care. And if they're unable to do that, it's going to come from program that districts offer. When I'm in the education space, you can translate as taking it away from kids, students. That's what it's come to in Monterey County.
2 minutes.
Taking away from kids. We needed help 10 years ago. It's getting to be too late. Please help us. Thank you.
Looking virtually, we've got one hand raised. Nikki, go ahead.
Hi, good afternoon. My name is Nikki Long. I'm the president of the Monterey Bay Teachers Association. And I really appreciate that you're weighing the vast needs across California and some really complex data here and then the knowledge of the situation in Monterey. So obviously, I think I could speak for a long time reiterating a lot of what you've heard, but I just want to focus on what you've just heard, which is the recent situation. For Monterey Peninsula Unified, we're having to pay over $800,000. So as an educator, you know, when we're sitting in bargaining, we think of between $450,000 and $500,000 a year is around the cost of a 1% raise for us. So that's a huge chunk of money. And then as the Salinas superintendent spoke to at the beginning of the call, we're facing this 12% increase in benefits. And I just want to speak to the reality of that. So a 12% increase from MCSIG obviously doesn't correlate to an increase instantly from our school district. You know, it can't till we go through bargaining at the least. But that means, for example, an employee, the employee-only plan, which excludes the community hospital of the Monterey Peninsula, the cost of the educator has increased from $32 to $131 a month. So that's a 310% increase per month. And the family PPO 60 has increased for an educator from $1,534 a month to $1,833 a month, which is about a 20% increase. So I understand the desire to move slowly and get this right, but there is real urgency here. And I'm concerned that the longer we wait, the more opportunity our local hospitals are finding to sort of get ahead of you and increase charges now. Maybe that's unfair, but there is real urgency here, and I appreciate you hearing me on that. Thanks so much.
Thank you. Going back to the room at the podium.
Good afternoon, Katie Bassler. I'll just say Salinas, Monterey County. To begin with, when I looked at the slides when they were posted, I thought, what is this jibber jabber? And I just want to acknowledge the work of the staff and Mr. Howard for all of your work, because it really was, you made it tangible. We appreciate the board's attention to Monterey County and the critical situation that the workers are in. From the charts, we see that CHOMP and Salinas Valley Health are in that top 15 or 30 on a couple of them. But this work has been going, or this concern has been happening for over a decade that I've been involved in healthcare. The representatives have shared that the rates charged by Chomp and Salinas Valley and Natividad have consistently been higher. And now, again, as Nikki just mentioned, and I'm so glad she was on this meeting, we're all in this together. It's no longer affordable for workers and for my constituents, educators. These are the people that manage hospitality in Monterey County, education and service, and we do not have options. At the August meeting, I want to recall that Covered California will only have one network starting in January. So there are very few options just on that platform. Furthermore, CalPERS mentioned that the rate setting for all of the 4 areas were impacted by Monterey County rates. It's clear what is happening in Monterey County. Yes, Kaiser begins in January, but not everyone is eligible in Monterey County for Kaiser, and the hospitals are not interested in having beds for Kaiser. So it's not an option.
2 minutes.
We urge you to move forward with option 4. We do think that it's the best plan. There is urgency, and I just hope that the hospitals are hearing us. Thank you.
Thank you. Looking virtually, seeing no hands raised, noting for the record we have about 86 virtual attendees at this time. Going back to the room.
Good afternoon, Ivana Krejcinovic with Unite Here Health, rounding out the Greek chorus from Monterey County. Every month we get up here and we wonder, is there anything new to say? Are they going to be sick of us? And then we see new data and new stories come forward. The Urban Institute came out with a study that shows that in Monterey County, the rate of medical debt is twice that of the rest of the state. And here again, we're an outlier. San Benito County next door is similar, and there are only a couple of counties in the far north that have a slightly higher rates of medical debt. And if you look at other forms of debt, Monterey County is actually a bit better than the California average. So it's not about general affordability or the cost of living as they often claim. This isn't, I think our concern is that we're going to make the perfect the enemy of the good here. We really feel, I think as you've heard from the previous speakers, that this is really urgent. I think you sent a really strong message in August and the hospitals have responded. You can see Montage's letter in your packet. They are making steps. It's not enough, but they are steps and they are concrete steps. We've yet to hear anything from Salinas Valley or Natividad. So there's still, this is a time to not take your feet off the gas. We also have more than 2,000 hotel workers on strike in San Francisco, and they've been on strike for weeks, and it's really impacting even the ability of that local economy to recover from the pandemic. Meeting and convention business is still struggling to come back in San Francisco, and that bargaining is solely about healthcare costs. So it's impacting workers, it's impacting employers, it's impacting the local economy. So we would also support option 4 because I think as was discussed here, option 2 actually could be a subset of option 4, but we really need the relief and we need it now. So we really hope that you can get these spending targets implemented this spring so that they're operational in 2026. Thank you.
Thank you. Looking virtually, seeing no hands raised, going back to the room.
Ben Johnson, California Hospital Association. I too don't want to just repeat myself from prior comments, but do have to share that California's hospitals are concerned with the push to implement cost spending sector targets at a time on a timeline that's moving too fast and too far and is coming faster than the timelines that were clearly contemplated in statute. The discussion is occurring before the spending data has been collected, analyzed, and reported, meaning OCA is basing the discussion on incomplete data that doesn't allow it, for example, to compare financial trends across segments of the healthcare delivery system. And the focus on hospitals is concerning, focusing on a field that is under severe financial distress, facing huge inflationary cost pressures as a result of the pandemic and other challenges, and whose stability is at risk as known and which hearken the creation of the Distressed Hospital Loan Program previously discussed. And according to the most recent data, is experiencing negative operating margins for the last measurement year on a statewide basis. The discussion and presentation today make clear that segmenting the hospital field is very complicated and that performance on one metric doesn't translate into performance on another. And clearly much more work is needed before going down the road to sector targets. So we urge OCA to proceed diligently and with a clear understanding of the trends across the healthcare sector before proceeding towards sector targets. Thank you.
Thank you. Looking virtually, seeing no hands raised, going back to the room.
Beth Capel, Health Access, California. Ms. Landsberg is smiling at me because of my well-known proclivity for going either first or last in such discussions. Like others, we support option 4, where you would define all hospitals as a sector, including both, as we understand it, both inpatient and outpatient spending. And then you would adjust targets for specific hospitals, presumably having developed various measures to do so. We think this is the most consistent with the vision in the law of how to proceed. We also caution the board that the requirement to set targets for individual healthcare entities is the responsibility of the board, and thus that will fall to you, even if there are parameters and measures and guidelines for what that is. We were troubled by a number of the exclusions, but we understand from staff that that's purely for the purpose of analysis. And like others, we compliment the staff on the amount of work they did to get us to that very detailed discussion. We have lots of technical questions about the metrics that were used today and more work to do, we think, on that. I think the board would agree with that. I also want to make the final point that we do have a lot of hospitals that start off at a very high base, however we measure it. The fact that we're talking about 250% of Medicare as being too high, when I think a few years ago in 2017, probably 2016 data, we were talking about 200 or 208% of Medicare as the metric, if I remember the earlier study by Dr. Kroenig correctly, tells us that it's all gone in the wrong direction. And so we are very troubled. I will say that we've known for a long time that costs are higher in Northern California than in Southern California. And so we look forward to further analysis and further discussion. Finally, one last point. Bart Memorials, if I recall correctly, is in South Lake Tahoe, and it's never been clear to me they actually thought they were part of California. So I would... And I come back to my earlier point that this data has not been used for this purpose previously, and there's a desk audit for completeness. There's not what any of us would consider a full audit. And so as we look at the data, we're going to have to both improve the data we collect and make sure that it's accurate for these purposes. And that's part of what was envisioned when we created OCA. Thank you.
Thank you. Seeing no hands raised virtually and no one at the podium, that concludes public comment on this item.
Thank you very much, and we will look forward to continued conversations on that topic. We will now move to item 6, general public comment, inviting general public comment for this afternoon.
If you'd like to make a comment, please step to the podium. Please raise your hand online. I'll give it a moment. Seeing no hands raised and no one stepping to the podium, that concludes public comment on this item.
Thank you all again for being here with us. Thanking all the public in the room and online. And we are looking forward to seeing you in the new year. That concludes our business this afternoon. Meeting adjourned.